Hello everyone, and welcome back to another chapter of Advanced Pathophysiology. Today we're talking about Chapter 18, Disorders of the Central and Peripheral Nervous System, and the Neuromuscular Junction. Apologies in advance, I am getting a cold, so I may sound a little off, but we're going to power on through, because we got to do what we got to do, right? So without much preamble, let's jump right into the chapter. Alterations in the CNS structure and function are caused by traumatic injury, vascular disorders, tumor growth, infectious and inflammatory processes, metabolic derangements, and degenerative processes. Alterations in peripheral nervous system function involve the nerve roots, a nerve plexus, the nerve themselves, or the neuromuscular junction. So, talking about central nervous system disorders, your traumatic brain and spinal cord injury. Traumatic brain injury, or TBI, is an alteration in brain function or other evidence of brain pathology caused by an external force. The most common cause are falls for children and older adults, followed by unintentional blunt trauma and motor vehicle accidents. Males have the highest incidence in every age group. The incidence of a TBI is highest among American Indian, Alaska Natives, and Blacks, and in lower and medium income families. In recent years, individuals with TBI have shown improved survival outcomes. Advancements have been made in enhanced safety measures, reduced transport time to hospitals or trauma centers, improved on-scene medical management, imaging of the TBI, prevention and management of secondary brain injury, and a better understanding of long-term consequences of all degrees of brain injury severity. TBI can be classified as primary or secondary. Primary TBI is caused by a direct impact or injury and can be focal, affecting one area of the brain, or diffuse, involving more than one area of the brain. Both types of injury can be associated with the same initiating event, focal brain injury and diffuse axonal injury. Each account for half of all injuries. Focal brain injury and diffuse axonal injury each account for half of all injuries. Focal brain injury accounts for more than 2/3 of head injury deaths, and DAI accounts for less than 1/3 of deaths. Secondary injury is an indirect consequence of the primary injury and includes systemic responses and a cascade of molecular and chemical events that affect the brain. TBI can be mild, moderate, or severe. The GCS system, or Glasgow Coma Scale, is commonly used to grade severity of injury. Other scales also may be used, including the Abbreviation Injury Scale, Injury Severity Score, and the length of post-traumatic amnesia. Most TBIs are mild. So here we're taking a look at brain injury, primary and secondary. So some of the secondaries are hypotension, hypoxia, cerebral ischemia, cerebral edema, excitotoxicity, oxidative stress. And again, the primaries are usually, direct impact, so skull fractures, contusions, hemorrhages. And then there's a molecular mechanism of neural injury. And this next table talks about the GCS, Glasgow Coma Scale. So, primary brain injury. Focal brain injury can be caused by blunt trauma or open penetrating trauma. Closed injury is more common and involves the head striking a hard surface, a rapidly moving object striking the head, or blast waves. The dura mater remains intact and brain tissue are not exposed to the environment. Blunt trauma can result in both focal brain injury and diffuse axonal injuries, and they can occur at the same time. Your open head injury involves a skull fracture and a break in the dura, results in exposure of the cranial content to the environment. Skull fractures include compound fracture or perforated fracture and linear, comminuted, and basilar skull fractures. Your closed head injuries are specific, grossly observable skull and brain lesions that occur in a precise location. Of blunt trauma injuries, 75 to 90% are considered mild. Injury to the cranial wall, vessel, and supporting structure can produce more severe damage, including contusions and epidural, subdural, subarachnoid, and intracerebral hematomas. The dura mater remains intact. The brain tissues are not exposed to the environment. Compression of the skull at the point of impact produces contusions or brain bruising from blood leaking from an injured vessel. The injury may be coup or contracoup. Coup meaning injury at the site of impact, or contracoup meaning injury from the brain rebounding and hitting the opposite side of the wall, or both. The severity of contusions vary with the amount of energy transmitted by the skull to the underlying brain tissue. The smaller the area of impact, the more severe the injury because of the concentration of force. Brain edema forms around and in damaged neural tissues, contributing to increased intracranial pressure, or ICP. Multiple hemorrhages, edema, infarction, and necrosis can occur within the contused area. The tissue has a pulpy quality. The maximal effects of these injuries peak between 18 to 36 hours after the head injury. So here we're taking a look at a cerebral contusion, a close-up. You can see the trauma to it. And here you can see how coup and contracoup brain injuries would occur. So you would see these usually in like accidents, car accidents, or anytime your head gets banged around a fair bit. Contusions are found most commonly in the frontal lobe, particularly at the poles and along the inferior orbital surface. In the temporal lobes, especially at the anterior poles and along the inferior surface, and at the frontotemporal junction. They cause changes in attention, memory, executive function, affect, emotion, and behavior. Less commonly, contusions occur in the parietal and occipital lobes. Focal cerebral contusions are usually superficial, involving just the gyri. Hemorrhagic contusions may coalesce into a large, confluent intracranial hematoma. A closed brain injury may be evidenced by immediate loss of consciousness, loss of reflexes, transient cessation of respiration, brief period of bradycardia, and decrease in blood pressure. Increased cerebrospinal fluid pressure and electrocardiogram and electroencephalopathy changes may occur on impact. Vital signs may stabilize to normal values in a few seconds. Reflexes then return and the person regains consciousness over minutes to days. Residual deficits may persist and some persons never regain a full level of consciousness. Evaluation is based on results of the health history, level of consciousness according to the GCS, outcomes of imaging studies, and assessment of vital parameters. Large contusions and lacerations with hemorrhage may be surgically excised. Treatment is otherwise directed at controlling ICP, neuroprotection, and managing symptoms. Epidural hematomas represent 1 to 2% of major head injuries and occur in all age groups, but most commonly in those 20 to 40 years of age. Extradural hematomas are caused, most commonly, by motor vehicle accidents, and occasionally by falls and sporting accidents. An artery is the source of bleeding in 85% of epidural hematomas, usually accompanied by a skull fracture, which is 15% of these injuries result from injury to the meningeal vein or dural sinus. The temporal fossa is the most common site of epidural hematoma caused by injury in the middle meningeal artery or vein. The temporal lobe shifts medially, precipitating uncal and hippocampal gyrus herniation through the tentorial notch. Epidural hemorrhages are found occasionally in the subfrontal area, especially in the young and elderly population, caused by injury to the anterior meningeal artery or venous sinus, and in the occipital, suboccipital area, resulting in herniation of the posterior fossa, contents through the foramen magnum. So here you can see how, if you look at it, you have a hematoma here that's pushing all the brain contents to the other side. Individuals with temporal epidural hematomas lose consciousness at injury. 1/3 of those affected then become lucid within a few minutes to a few days. As the hematoma accumulates, a headache of increasing severity, vomiting, drowsiness, confusion, seizure, and hemiparesis may develop. Because temporal lobe herniation occurs, the level of consciousness is rapidly lost, with ipsilateral pupillary dilation and contralateral hemiparesis. A CT scan or MRI is usually needed to diagnose epidural hematomas. The prognosis is good if intervention is initiated before bilateral dilation of the pupils occurs. Epidural hematomas are almost always medical emergencies, requiring monitoring and evaluation and surgical evacuation of the hematoma. Subdural hematomas arise in 10 to 20% of TBIs. Acute subdural hematomas develop rapidly, usually within hours, and are commonly located at the top of the skull. Bilateral hematomas occur in 50% to 20% of persons. The expanding clot directly compresses the brain. As the ICP rises, the bleeding veins are compressed. Thus, bleeding is self-limiting, although cerebral compression and displacement of the brain tissue can cause temporal lobe herniation. Symptoms classically begin with a headache, drowsiness, restlessness, or agitation, slow cognition, and confusion. These symptoms worsen over time and progress to loss of consciousness, respiratory pattern changes, and pupillary dilation. Homonymous hemianopia, a defective vision in either the right or the left field. Disconjugate gaze and gaze palsies also may occur. Subacute subdural hematomas develop more slowly, often over 48 hours to 2 weeks. Bridging veins tear, causing both rapid and subacute developing subdural hematomas. Although torn cortical veins or venous sinuses and contused tissue also may be the source, they occur more commonly in older adults and those who abuse alcohol because they have some degree of brain atrophy, with a subsequent increase in the size of the extradural space. These subdural hematomas act like expanding masses, increasing ICP that eventually compresses the bleeding vessels. Brain herniation can result. So here you see the subdural hematoma. Chronic subdural hematomas develop over weeks to months. The existing subdural space contains the liquefied clot from the acute bleed and/or accumulation of blood from a leaking vein. A vascular membrane forms around the hematoma in approximately 2 weeks. Of those individuals affected by the chronic subdural hematoma, 80% have chronic headaches and tenderness over the hematoma on palpation. They may have confusion, memory loss, or coma. difficulty speaking or swallowing, and weakness with difficulty walking, loss of sensation or seizure. Chronic subdural hematomas require craniotomy to evacuate the gelatinous blood and to prevent brain herniation. Percutaneous drainage for chronic subdural hematomas has proven successful. However, reaccumulation often occurs. Subarachnoid hemorrhages is present here in the section on subarachnoid hemorrhage. So here you're looking at chronic subdural hematomas and the compression of the underlying brain tissue. Intracerebral bleeding or intracerebral hematoma occur in 2% to 3% of head injuries. They may be single or multiple and are associated with contusions, although most are commonly located in the frontal and temporal lobe. Intracerebral hematomas may occur in the hemispheric deep white matter. Penetrating injury or shearing forces traumatize small blood vessels. The intracerebral hematoma then acts as an expanding mass, increasing ICP, compressing brain tissue, and causing edema and ischemia. Delayed intracerebral hematomas may appear 3 to 10 days after the head injury. Intracerebral hematomas also can occur with non-traumatic brain injury, such as a hemorrhagic stroke. So here you are looking at the acute intracerebral hemorrhage. Intracerebral hematomas cause a decreasing level of consciousness, coma, or a confusional state from other injuries. However, can make the cause of the increasing unresponsiveness difficult to detect. Contralateral hemiplegia also may occur, and as ICP rises, temporal lobe herniation may appear. In delayed intracerebral hematoma, the presentation is similar to that of a hypertensive brain hemorrhage, with sudden, rapidly progressive, decreased level of consciousness, with pupillary dilation, breathing pattern changes, hemiplegia, and bilateral positive Babinski reflexes. Your history and physical examination help to establish the diagnosis of, and your CT scan, MRI, and cerebral angiography confirms it. Evacuation of a singular intracerebral hematoma has only occasionally been helpful, mostly for subcortical white matter hematomas. Otherwise, treatment is directed at reducing ICP to maintain cerebral perfusion pressure and allowing the hematoma to reabsorb slowly. Secondary injury is common. Your open brain trauma produces both focal and diffuse injuries and includes compound skull fractures and missile injuries. The mechanism of open brain trauma are crush injury and stretch injury. A compound skull fracture opens a communication between the cranial content and the environment and should be investigated whenever there are lacerations of the scalp, tympanic membrane, a sinus, an eye, or mucous membranes. Such fractures may involve the cranial vault or the base of the skull. A basilar skull fracture can involve the temporal, sphenoid, and occipital bones. Severity of brain damage is related to the severity of skull fracture. Infection is a significant complication. Bone fragments or debris from projectiles may contuse brain tissue or lacerate blood vessels. Most victims lose consciousness with an open head injury. The depth and duration of the coma are related to the location of the injury, extent of damage, and amount of bleeding. Open brain injury often requires debridement of the traumatized tissue to prevent infection and to remove blood clots and debris, thereby reducing ICP. ICP also is managed with dehydrating agents, osmotic diuretics, or a combination of these drugs. A compound fracture may be diagnosed through physical examination, skull radiographs, or both. Basilar skull fracture is determined on the basis of clinical findings. Skull radiographs often do not demonstrate the fracture, although intracranial air or air in the sinuses on radiograph, CT or MRI is indirect evidence of a basilar skull fracture. A compound fracture is debrided, and bone grafts may be required. Antibiotics are administered after surgery. Bed rest and close observation for meningitis and other complications are prescribed for a basilar skull fracture. That leads us to diffuse axonal injury. Diffuse axonal injury involves neurons in widespread areas of the brain and occurs with all severities of brain injury. Mechanical effects from high levels of acceleration and deceleration, such as whiplash and rotational force, cause stretching and shearing of the delicate axonal fibers and white matter tracts that project to the cerebral cortex. The most severe axonal injuries are located more peripheral to the brainstem, causing extensive cognitive and affective impairments. Axonal damage reduces the speed of information processing and responding and disrupts cognitive function. Pathophysiologically, axon damage axonal damage can be seen only with an electron microscope and involves numerous axons, either alone or in conjunction with actual tissue tear. Advanced imaging techniques using MRI are assisting to define areas and extent of injury. Areas where axons and small blood vessels are torn appear as small hemorrhages, located particularly in the parasagittal white matter near the cerebral cortex, corpus callosum, and brainstem, and at the superior cerebellar peduncle. More damaged axons are visible 12 hours to several days after the initial injury. The severity of DAI correlates with the amount of shearing force. DAI is not associated with intracranial hypertension immediately after injury. However, acute brain swelling from increased intravascular blood flow within the brain, loss of cerebrovascular autoregulation, vasodilation, and increased cerebral blood volume is often seen and can result in death. DAI may induce long-term neurodegenerative processes with progressive axonal pathology that may continue for years after injury and may play a role in the development of chronic traumatic encephalopathy and Alzheimer's disease-like pathologic changes. So here you're taking a look at the diffuse axonal injury. There is currently a lack of consensus regarding the terminology to grade or define the clinical syndromes associated with TBI, and several categories exist: mild concussion and classic concussion, and mild, moderate, and severe TBI. The symptoms associated with grade of concussion or TBI are often the same. Concussion has been described as a set of symptoms with or without neuropathologic damage that may or may not involve loss of consciousness following TBI. However, with new imaging techniques and discovery of molecular markers associated with mild and moderate TBI, it is likely that DAI occurs in mild, moderate, and severe TBI. Methods of grading severity of TBI are arbitrary, with the GCS most commonly used along with clinical evaluation of neurologic function. Recommendations are available to direct imaging of TBI. The discussion presented here considers the severity of grades of concussion and TBI at the same time. So if you want to read about what's new in regards to your biomarkers and concussion, as always, I recommend hit pause. Otherwise, I keep going. I'll leave it up as I'll leave it up as best as I can and read the bottom portion, seeing as it's a little small section. But in general, if there's a section that I'm like brushing over too quickly, please pause and read over it. Mild traumatic brain injury or mild concussion is characterized by immediate but transitory clinical manifestations without the loss of consciousness, or loss of consciousness that is momentarily or less than 30 minutes. Most blunt trauma injury causes mild TBI. The GCS is 13 to 15. Post-traumatic anterograde amnesia also may exist, transiently to less than 24 hours. There may be no findings with diagnostic imaging. Persons may experience headaches, nausea, and vomiting, confusion, disorientation, attention deficit, dizziness, and impaired ability to concentrate for days after the injury. Diffuse axonal injury, metabolic impairment, alterations in neural activation, and cerebral blood flow perturbations can occur and may contribute to the acute symptomatology. Lesions may be detected with advanced MRI imaging. Biomarkers are under investigation to assist with diagnosis of mild TBI. Moderate TBI, or traumatic brain injury, is any loss of consciousness lasting more than 30 seconds. Moderate traumatic brain injury is any loss of consciousness lasting more than 30 minutes, accompanied by post-traumatic anterograde amnesia lasting 24 hours or more. A GCS between 8 and 13 is classified as moderate TBI. A basal skull fracture may be present with moderate TBI, but there is no brainstem injury. There is transitory decerebration or decortication, with unconsciousness lasting days to weeks. The person is confused and experiences a long period of post-traumatic amnesia. There often are permanent deficits in selective attention, vigilance, detection, working memory, data processing, vision or perception, and language, as well as mood and affect changes ranging from mild to severe. Severe traumatic brain injury is a GCS less than 8 and is associated with brainstem signs, pupillary reaction, cardiac and respiratory symptoms, posturing, and intracranial contusion, hematomas, or lacerations. Loss of consciousness lasts more than 24 hours. The person experiences immediate autonomic dysfunction that resolves in a few weeks. Increased ICP appears 4 to 6 days after injury. Pulmonary complications occur frequently, with profound sensory, motor, and cognitive system deficits. Severely compromised coordinated movements and verbal and written communication, inability to learn and reason, and inability to modulate behavior also are evident. Severe injury causes permanent neurologic deficits, 20% of adults, and it has been shown that up to 14% remain in a vegetative state, and 20 to 40% of patients end up dying as a result of the brain injury, of secondary complications. The goal of treatment is to maintain cerebral perfusion and oxygenation, promote neuroprotection, and mitigate long-term neurologic deficits. The corticosteroid randomization after significant head injury trial showed corticosteroids increase mortality with acute TBI. Consequently, these drugs are no longer used. Guidelines are available to direct evaluation and treatment. Secondary brain injury is an indirect result of primary brain injury, including trauma and stroke syndromes. Systemic and cerebral processes are contributing factors. Systemic processes include hypotension, hypoxia, anemia, hypoglycemia, hyperglycemia, and hypercapnia or hypocapnia. Cerebral contributions include inflammation, oxidative stress, alterations in the blood-brain barrier, excitotoxicity, cerebral edema, increased intracranial pressure, decreased cerebral perfusion pressure, cerebral ischemia, and brain herniation. Cellular and molecular brain damage from the effects of primary injury develop hours to days later. Cerebrovascular autoregulation is impaired after brain injury and may be transient or persistent with alterations in CO2 reactivity. Vasospasm commonly occurs contributing to brain hypoperfusion and is caused by chronic depolarization of vascular smooth muscle, release of endothelium, and decreased availability of nitric oxide. Ischemia contributes to excitotoxicity with release of excitatory neurotransmitters, such as glutamate, that escapes from stretched and injured neurons. They cause cellular influx of calcium and stimulate neuronal hyperexcitability by depolarizing the membrane potential. A hypermetabolic state, poor perfusion, influx of inflammatory mediators, fluctuations in cellular sodium and potassium ion channels, and mitochondrial failure all contribute to cytotoxic edema, axonal swelling, and neuronal death. Mitochondrial failure, anaerobic metabolism, lactic acid production, and increased levels of reactive oxygen species, your ROS, your phospholipases, and other enzymes damage proteins and the phospholipid components of cell and organelle membranes. Cell swelling, vascularization, and ultimately necrotic or programmed cell death occurs. These events lead to failure of the capillary blood-brain barrier and vasogenic edema. The influx of sodium and water results in intracellular cytotoxic edema in neurons, astrocytes, and microglia, irrespective of the integrity of the vascular endothelial wall. Edema increases ICP, contributing to tissue hypoxia and cerebral ischemia. Inflammation occurs immediately and persists for weeks. Inflammation is critical for wound healing. Immune cells, including neutrophils, macrophages, and T cell lymphocytes, need to infiltrate injured tissue and clear debris, thus promoting formation of scar tissue. However, an overactive response leads to occlusion of the microvasculature with leukocytes and platelets. The release of inflammatory cytokines, proteases, free radicals, prostaglandins, and complement proteins alter the blood-brain barrier and causes vasoconstriction, brain edema, increased ICP, reduced cerebral perfusion, and ischemia, aggravating secondary brain injury. Activation of astrocytes and microglia contribute to persistent neuroinflammation, alters the blood-brain barrier, and can cause progressive neurodegeneration that occurs over weeks after the traumatic injury. Intracranial hemorrhage, whether traumatic or related to a stroke syndrome, may contribute to secondary brain injury. The bleeding is often accompanied by increased ICP, ischemia, oxidative damage, and vasogenic and cytotoxic edema, as previously described. In addition, the vascular injury can cause activation of platelets, which contribute to vasoconstriction in large arteries and vasodilation in small arteries, with spreading cortical ischemia. Activated platelets also trigger the release of free radicals from granulocytes, enhancing oxidative stress. Vascular injuries causes coagulation disorders from release of increased amounts of tissue factor from endothelial cells, which initiates the coagulation cascade and overwhelms the normal factors that control coagulation. Free heme and free iron are released from red blood cells, and both cause the the induction of free radicals, lipid peroxidation, and further nerve damage. The management of secondary brain trauma includes removal of hematomas and management of hypotension, hypoxia, hypoxemia, anemia, ICP, fluid and electrolyte balance, body temperature, ventilation, and nutrition. Numerous agents are under investigation and may be neuroprotective by decreasing excitotoxicity, neuroinflammation, apoptosis, mitochondrial failure, the blood-brain barrier disruption, edema, and other mechanisms of secondary injury. Progress is difficult because of lack of predictive biomarkers and drugs that can cross the blood-brain barrier. Fluid and nutrition management have emerged as critically important in the care of individuals with severe brain injury. Long-term recovery can be influenced by systemic complications such as pneumonia, fever, infection, and immobility. So complications of TBIs. Many complications are associated with TBI and are related to severity of injury and the parts of the brain that are affected. Altered states of consciousness can range from confusion to deep coma. Cognitive deficits, hydrocephalus, and sensory motor disorders, including pain, paresis, and loss of coordination, may be present. Three of the most common post-traumatic brain syndromes are summarized next. Post-concussion syndrome occurs with mild TBI, including sports concussions. Symptoms are nonspecific and include a headache, dizziness, fatigue, nervousness or anxiety, irritability, insomnia, photophobia, depression, inability to concentrate, and forgetfulness. It may last for weeks to months. Treatment entails reassurance and symptomatic relief in addition to 24 hours of close observation after the concussion in the event bleeding or swelling in the brain occurs. Symptoms requiring further evaluation and treatment include drowsiness or confusion, nausea or vomiting, a severe headache, memory deficits, seizures, drainage of CSF from the ear or nose, weakness or loss of feeling in the extremities, asymmetry of the pupils, and double vision. Guidelines for the management of pediatric and adult mild TBI are available. Guidelines also have been published for the management of sports-related concussion, your post-traumatic seizures, or epilepsy, occurs in about 10% of TBIs, with the highest risk among open brain injuries. Seizures can occur early, within days, or up to 2 to 5 years, or longer after the trauma. Causal mechanisms are poorly understood, and cellular and molecular changes in the brain associated with injury and repair, such as sprouting of new neurons with hyperexcitability and decreases in GABAergic inhibition, may cause hyperexcitability states that lead to epileptogenesis. Seizure prevention using drugs such as phenytoin is initiated for moderate to severe TBI at the time of injury. Neuromodulation with implantable devices is under evaluation. Clinical trials are ongoing to test drugs that prevent the development of post-traumatic seizures. Chronic traumatic encephalopathy is a progressive dementing disease that develops with repeated brain injury associated with sporting events, blast injuries in soldiers, or work-related head trauma. Tau neurofibrillary tangles are present in the brain. Your chronic traumatic encephalopathy is associated with violent behaviors, loss of control, depression, suicide, memory loss, and cognitive changes. Research in the progress to discover the mechanistic link between neurotrauma and chronic traumatic encephalopathy. It is diagnosed from history and clinical evaluation and at autopsy. Spinal cord vertebral injury. Approximately 282,000 people were living with a spinal cord injury in the US, with roughly 17,000 new cases in 2016. About 80% are males, and average age is about 42 years. Since 2010, the causes include vehicle crashes, falls, violence, and sports. The extent of injury has been 45% incomplete quadriplegia, 14% complete quadriplegia, 21% incomplete paraplegia, and 20% with complete paraplegia. So, pathophysiology. Primary spinal cord injury occurs with the initial mechanical trauma and immediate tissue destruction from shearing, compression, or penetration. Injury to the cord is summarized in the following table. Primary spinal cord injury also can occur if an injured spine is not adequately immobilized immediately following injury. Primary spinal cord injury may occur in the absence of vertebral fracture or dislocation from longitudinal stretching of the cord with or without flexion or extension of the vertebral column or both. The stretching causes altered axon transport, edema, myelin degeneration, and retrograde or Wallerian degeneration. So here we have different kinds of injuries and their descriptions. Your cord concussion, your cord contusion, cord compression, laceration, transection, whether it's complete or incomplete, a preserved sensation only, preserved motor non-functional, preserved motor functional, hemorrhage, and damage or obstruction of spinal blood supply. So I always recommend a pause so you can read all these. Secondary spinal cord injury is a pathophysiologic cascade of vascular, cellular, and biochemical event that begins within a few minutes after injury and continues for weeks. Edema, ischemia, excitotoxicity, inflammation, oxidative damage, and activation of necrotic and apoptotic cell death signals events similar to those previously described for TBI. With secondary spinal cord injury, microscopic hemorrhages appear in the central gray matter and pia arachnoid, increasing in size until the entire gray matter is hemorrhagic and necrotic. Edema in the white matter occurs, impairing the microcirculation of the cord. Hemorrhages and edema are followed by loss of autoregulation and reduced vascular perfusion and development of ischemic areas, which are maximal at the level of injury and two cord segment above and below it. Cellular and subcellular alterations with myelin disruption, axonal degeneration, and tissue necrosis occurs. Impaired perfusion is aggravated by systemic responses, including neurogenic or hemorrhagic shock, and dysrhythmias. Cord swelling increases the individual's degree of dysfunction, making it difficult to distinguish functions permanently lost from those temporarily impaired. In the cervical region, cord swelling may be life-threatening. Diaphragm function may be impaired because phrenic nerves exit at C3 to C5. Cardiovascular and respiratory functions mediated by the medulla oblongata can be lost. Efforts are in progress to identify biomarkers that reflect severity of injury and guide treatment. Circulation in the white matter tracts of the spinal cord return to normal in about 24 hours, but gray matter circulation remains altered. Your phagocytes appear 36 to 48 hours after injury, and microalgia proliferate with altered astrocytes, promoting inflammation. Red blood cells begin to disintegrate, and resorption of hemorrhages and edema begins. Degenerating axons are engulfed by macrophages in the first 10 days after injury. The traumatized cord is replaced by acellular collagenous tissue, usually in 3 to 4 weeks. The meninges thicken as part of that scarring process. Vertebral injuries result from acceleration, deceleration, rotation, or deformation forces at impact. These forces cause vertebral fractures, dislocation, and bone fragments that can cause compression or exert traction on the tissue, or shear tissues so they slide into one another. Vertebral injuries can be classified as simple fracture, a single break, usually affecting transverse or spinous processes; compressed vertebral fracture, that is, a vertebral body compressed anteriorly; comminuted or burst fracture, vertebral body shattered into several fragments; and dislocation. So here you're taking a look at the hyperextension injuries of the spine. Whether it's a hyperextension injury of the spine that can result in fracture or non-fracture injuries with spinal cord damage. And then you see the flexion injury of the spine with hyperflexion. And here you can take a look at the axial compression and a flexion rotation injury. So I'll leave that up for just a moment. The vertebra fracture readily with direct and indirect trauma. When the supporting ligaments are torn, the vertebra move out of alignment and dislocation occurs. A horizontal force moves the vertebra straight forward. If the individual is in a flexed position at the time of injury, the vertebrae are then in an angulated position. Flexion and extension injuries may result in dislocations. Vertebral injuries in adults occurs most often at vertebra C1 and C2, C4, C7, T10, and L2. The most mobile portion of the vertebral column, the spinal cord, occupies most of the vertebral canal in the cervical and lumbar regions, so it can also be easily injured in these locations. So again, here are different types of mechanisms of vertebral injury. Again, your hyperextension, hyperflexion, vertical compression, and rotational force. Clinical manifestations. Spinal shock develops immediately after injury because of the loss of continuous tonic discharge from the brain or brain stem and inhibition of suprasegmental impulses caused by cord hemorrhage, edema, or anatomic transection. All motor, sensory, reflex, and autonomic functions cease below any transected area and may cease below concussive, contused, compressed, or ischemic areas. There is flaccid paralysis, absence of sensation, loss of bladder and rectal control, transient drop in blood pressure, and poor venous circulation. The condition also results in disturbed thermal control because the sympathetic nervous system is damaged. The hypothalamus cannot regulate body heat through vasoconstriction and increased metabolism. Therefore, the individual assumes the temperature of the air. Spinal shock generally lasts 7 to 20 days, with a range of a few days to 3 months. It terminates with the reappearance of reflex activity, hyperreflexia, spasticity, and reflex emptying of the bladder. The following table summarizes the clinical manifestations of a spinal cord injury. So again, there's different stages and its manifestations. So for instance, spinal shock, the complete spinal cord transection or a partial spinal cord transection. Hit pause so you can read all of the manifestations. And then your heightened reflex activity stage. Neurogenic shock, also called vasogenic shock, occurs with cervical or upper thoracic cord injury above T6 and may be seen in addition to spinal shock. Neurogenic shock is caused by the absence of sympathetic activity through loss of supraspinal control and unopposed parasympathetic tone mediated by the intact vagus nerve and may last up to 5 weeks after injury. Symptoms include vasodilation, hypotension, bradycardia, and hypothermia. Neurogenic shock may be complicated by hypovolemic or cardiogenic shock if there is concurrent heart failure or blood loss. Continued loss of motor and sensory function depends on the extent and level of injury. Paralysis of the lower half of the body with both legs involved is termed paraplegia. Paralysis involving all 4 extremities is called quadriplegia. Incomplete quadriplegia, the level of injury is above C6, and all upper extremity function is lost. In incomplete quadriplegia, function at or above C6 is preserved, leaving the shoulder, upper arm, and some forearm muscles control intact. With acceleration injuries, the greatest stress point is C4 and C5. With a deceleration force, the greatest stress point is at C5 and C6. The initial clinical manifestation associated with acute spinal cord injury are rapid loss of voluntary movements in the body parts below the level of injury, loss of sensation in the lower extremities and possible lower trunk, and loss of spinal and autonomic reflexes below the level of injury. The duration of this reflexic state is highly variable. In most people, reflex activity returns in 1 to 2 weeks. Return of spinal neuron excitability occurs slowly. Depending on the degree of damage, either of the following can occur. Motor, sensory, reflex, and autonomic function return to normal, or autonomic neural activity is in the isolated segment developments. Spasticity is common with hyperreflexia, clonus, and painful muscle spasms. Sometimes after several months, episodes of autonomic hyperreflexia can occur. Your autonomic hyperreflexia is a syndrome of sudden life-threatening massive reflex sympathetic discharges associated with a spinal cord injury at level T6 or above, where descending inhibition is blocked. It may occur after spinal shock resolves and can be a recurrent complication. Characteristics include paroxysmal hypertension, a pounding headache, blurred vision, sweating above the level of the lesion with flushing of the skin, nasal congestion, nausea, piloerection caused by a pilomotor spasm, and bradycardia. The symptoms may develop singly or in combination. The condition can cause serious complications, strokes, seizures, MIs, and death, and require immediate treatment. So here we're looking at spinal cord injuries. The autonomic hyperreflexia and the autonomic dysreflexia. In autonomic hyperreflexia, sensory receptors below the level of the cord lesion are stimulated. The intact autonomic nervous system reflexively responds with an arteriolar spasm that increases blood pressure. Baroreceptors in the cerebral vessels, the carotid sinus, and the aorta sense the hypertension and stimulate the parasympathetic system.
Here's some info about sense.
The heart rate decreases, but the visceral and peripheral vessels do not dilate because efferent impulses cannot pass through the cord. The most common cause is a distended bladder or rectum. However, any sensory stimulation can elicit autonomic hyperreflexia. Emptying of the bladder or bowel usually relieves the syndrome, and the head of the bed should be elevated. Drug therapy, including nifedipine and nitrates, may be required to lower blood pressure and reduce complications. Bladder, bowel, and skincare management are important preventative strategies. Education of the individual and family regarding triggers and acute management is important, as is wearing a medic alert tag. So, our evaluation and treatment. Diagnosis of spinal cord injury is made on the basis of the physical examination and imaging studies, your MRIs. Neurogenic shock must be differentiated from the other kinds of shock. For a suspected or confirmed vertebral fracture or dislocation, regardless of the presence or absence of spinal cord injury, the immediate intervention is immobilization of the spine to prevent further injury. Decompression and surgical fixation should be performed early. High-dose methylprednisolone steroid therapy has been given within 8 hours of time of injury to decrease secondary cord injury. There are no clinical trials indicating this treatment is effective, and more research is needed. Therapeutic hypothermia has shown to some encouraging evidence for improved outcomes, particularly for cervical cord injuries. But again, more research is needed. Clinical trials are in progress to treat acute spinal cord injury, including cell-based therapies, immune modulators, vasculature selective treatments, functional electrical stimulation, and tissue engineering. Nutrients, lung function, skin integrity, particularly prevention of pressure ulcers, and bladder and bowel management must be addressed. Plans for rehabilitation require early consideration. Impairments are permanent because endogenous repair events fail to restore the damaged axonal circuitry. Degenerative disorders of the spine, your lower back pain. Lower back pain affects the area between the lower rib cage and gluteal muscles and often radiates into the thighs. The percentage of the population affected with recent lower back pain is about 29%, with a higher percentage among older individuals, particularly women older than the age of 60. Most people will experience back pain at some point in their lives. Lower back pain is the primary cause of disability worldwide. The burdens of disability include psychological, financial, occupational, and social effects on the person and family members. Risk factors include occupations that require repetitive lifting in the forward bent and twisted position, exposure to vibrations caused by vehicles or industrial machinery, obesity, and cigarette smoking. The pathology, or pathophysiology rather. Most cases of lower back pain are idiopathic or nonspecific, and no precise diagnosis is possible. Acute lower back pain is often associated with muscle or ligament strain and is more common in individuals younger than 50 years of age without a history of cancer. Common causes of chronic lower back pain include degenerative disc disease and lumbar disc herniation. Genetic causes include ischemic spondylolisthesis. Vertebra slides forward or slips in relation to the vertebra below. Spinal osteochondrosis and spinal stenosis associated with achondroplasia. Other causes include tension caused by tumors or disc prolapse, bursitis, synovitis, rising venous and tissue pressure, abnormal bone pressure, spinal immobility, inflammation caused by infection, and pain referred from viscera or the posterior peritoneum. Systemic causes of lower back pain include bone disease such as osteoporosis or osteomalacia and hyperparathyroidism. Anatom- anatomically, anatomically, low back pain must originate from innervated structures, but deep pain is widely referred and varies. The nucleus pulposus has no intrinsic innervation, but when extruded or herniated through a prolapsed disc, it irritates the spinal nerve dural membranes and causes pain referred to segmented areas. Discogenic pain also may be related to nerve sprouting and inflammation within the disc. The interspinous bursa can be a source of pain between L3, 4, 5, and S1, but also may affect L1, 2, and 3 spinous processes. The anterior and posterior longitudinal ligaments of the spine and the interspinous and supraspinous ligaments are abundantly supplied with pain receptors, as is the ligamentum flavum. All of, all of these ligaments are vulnerable to traumatic tears and fractures. So clinical manifestations, about 1% of individuals with acute lower back pain have sciatica, or pain along the distribution of the lumbar nerve root, most commonly involving the sciatic nerve. Sciatica is often accompanied by neurosensory and motor deficits, such as tingling, numbness, and weakness in various parts of the leg and foot. Major or progressive motor or sensory deficit, cauda-equina syndrome, history of cancer metastasis to the bone, and suspected spinal infection can be associated with chronic lower back pain. So, evaluation and treatment. Diagnosis of lower back pain is based on the history and physical exam. Imaging and nerve conduction studies are obtained with severe neurologic deficit or serious underlying disease. Diagnosis and treatment. Guidelines are available to plan therapy. Most individuals with acute lower back pain benefit from nonspecific short-term treatment, including nonsteroidal anti-inflammatory medications, exercises, physical therapy, and education. Individuals with chronic lower back pain can be treated with anti-inflammatory and muscle relaxant medications, exercise programs, massage, topical heat, spinal manipulation, acupuncture, cognitive behavior therapy, and interdisciplinary care. There is scant evidence for efficacy of opioids for chronic lower back pain, and there is high risk for addiction. Surgical treatments for identified pathologic conditions include discectomy and spinal fusion. Radiotherapy is used for treatment for facet-related pain after diagnostic nerve block. Evaluation of treatment outcomes should include pain function and quality of life. That leads us to spondylolysis. Spondylolysis is a structural defect in the pars interarticularis of the vertebral arc. The lumbar spine at L5 is affected most often. Mechanical pressure may cause an anterior displacement of the deficient vertebra. This defect occurs on the portion of the lamina between the superior and inferior articular facets, called the pars interarticularis. Heredity plays a significant role, and spondylolysis is associated with an increased incidence of other congenital spinal defects. As a result of torsional and rotational stress, microfractures occur at the affected site and eventually cause dissolution of the pars interarticularis. Symptoms include lower back pain and lower limb pain. Cervical spondylolysis is a facet hypertrophy and disc degeneration with narrowing in the cervical spine, predominantly at C5 and C6, and C6 and C7. It may present as a cervical radiculopathy, as a cervical myelopathy. Clinical manifestations of cervical radiculopathy include neck or occipital pain, as well as pain in the medial aspect of the scapula, shoulder, or arm. Sensory symptoms, such as tingling or numbness, follow a dermatomal pattern. Weakness follows the pattern of innervation of the affected nerve root. Occipital or suboccipital headache is another symptom. Cervical myelopathy can also cause difficulty walking, altered sensation in the feet, and sphincter disturbances. Your spondylolithiasis is an osseous defect of the pars interarticularis, allowing a vertebra to slide forward in relation to the vertebra below, commonly occurring between L5 and S1. It is more prevalent in adolescent athletes. Grades 1 and 2 have symptoms of pain in the lower back and butt, muscle spasm in the lower back and legs, and tightening hamstrings. Conservative management include exercise, rest, and back bracing. Vertebral slippage in grades 3 and 4 usually requires surgical decompression, stabilization, or both. Spinal stenosis. Spinal stenosis is the narrowing of the spinal canal that causes pressure on the spinal nerves or cord and can be congenital or acquired and associated with trauma or arthritis. It is categorized by the area of the spine affected, cervical, thoracic, or lumbar. Acquired conditions include the bulging disc, facet hypertrophy, or a thick ossified posterior longitudinal ligament. Symptoms are related to the area of the spine affected and can produce pain, numbness, and tingling in the neck, hands, arms, or legs, with weakness and difficulty walking. Surgical decompression is recommended for those with chronic symptoms and those who do not respond to medical management. Degenerative disc disease, or DDD, is common in individuals 30 years of age and older. It is, in part, a process of normal aging as a response to continuous vertical compression of the spine. DDD includes a genetic component involved overexpression of genes that code the cartilage intermediate layer protein. The combination of environment interactions and genetic predisposition increases susceptibility to non-traumatic lumbar disc disease by disrupting normal building and maintenance of cartilage. Causes include biochemical, inflammatory mediators, and biomechanical alterations, mechanical loading and compression of the intervertebral disc tissue. An example is the loss of disc proteoglycans and collagen with disc dehydration and loss of hydrostatic pressure, alters disc structure and function. The annulus can tear and the disc can herniate, pinching nerves or placing strain on the spine. Fibrocartilage replaces the gelatinous mucoid material of the nucleus pulposus as the disc changes with age. There may be shrinkage of the nucleus pulposus that produces prolapse or folding of the annulus, with secondary osteophyte formation at the margins of the adjacent vertebral body. The pathologic findings in DDD include disc protrusions, spondylolysis, and/or spondylolithiasis. Degeneration of vertebra and spinal stenosis. Lumbar disc disease causes one-third of all back pain that affects 70 to 90% of adults at some point in their lives. However, only a small percentage of people with DDD have any functional incapacity because of pain. Symptoms result from either protrusion of the disc or annulus, or narrowing of the spinal cord or intervertebral foramen by osteophytes. A congenital narrow canal or congenitally short pedicles may be present. Posterior disc protrusions in the cervical, thoracic, and lumbar regions lead to spinal cord compression, causing myelopathy. Posterior lateral disc protrusions, with or without a contribution from the vertebral body, or apophyseal joint osteophytes, lead to nerve root compression, causing radiculopathy. Thoracic disc disease is rarely symptomatic. Lumbosacral disc disease involves degeneration of the lower two lumbar discs in 90% of people. There may be lateral disc protrusion, manifesting as pain referred to the anterior thigh and leg, posterior lateral disc protrusion, or central disc protrusion, manifesting with pain, lower extremity weakness, impaired sphincter function, and saddle anesthesia. Clinical manifestations of posterolateral protrusion include pain in the back, the sacroiliac joint, and the medial aspect of the butt and upper thigh. Radicular pain exacerbated by movement and straining. Sensory symptoms that are common and segmental in distribution: focal tenderness on palpation of the back, limited range of motion in the back, and scoliosis secondary to paravertebral spasms. Restricted straight leg raising, positive femoral stretch tests, and focal signs that are determined by the root affected. So here you see different muscles and their reflexes and where they would be located on the foot. Herniated intervertebral disc. Herniation of the intervertebral disc is a displacement of the nucleus pulposus or annulus fibrosus beyond the intervertebral disc space. Rupture of an intervertebral disc is usually caused by trauma, degenerative disc disease, or both. Risk factors are weight-bearing sports, lightweight lifting, and certain work activities, such as repeated lifting. Men are more affected than women, with the highest incidence in the 30s to 50s age group. The lumbosacral discs L4 through L5 and L5 through S1 are most commonly affected. Herniation is typically at higher vertebra in older person. Disc herniation occasionally occurs in the cervical area, usually C5, C6, and C6, C7. Herniation at the thoracic level is extremely rare. The herniation may occur immediately, within a few hours, or months to years after the injury. So here you're taking a look at an X-ray, and it shows how there is the disc bulge and protrusion and herniation. And here you see the herniated nucleus pulposus. So, pathophysiology. In a herniated disc, the ligament and the posterior capsule of the disc usually are torn, allowing the gelatinous material to extrude and compress the nerve root. The vascular supply may be compromised and cause inflammatory changes in the nerve root. Occasionally, the injury tears the entire disc loose, causing the disc capsule and nucleus pulposus to protrude onto the nerve root or compress the spinal cord. Multiple nerve root compressions may be found at the L5 and S1 area, where the cauda equina may be compressed, causing cauda equina syndrome. So what kind of clinical manifestations do we see? The location and size of the herniation into the spinal canal, together with the amount of space in the canal, determine the clinical manifestations associated with the injury. Compression or inflammation or both of the spinal nerve result from disc herniation follows a dermatomal distribution called radiculopathy. A herniated disc in the lumbosacral area is associated with pain that radiates along the sciatic nerve course over the buttocks and into the calf or ankle. The pain occurs with straining, including coughing and sneezing, and usually on straight-legged raising. Other clinical manifestations include limited range of motion of the lumbar spine, tenderness on palpitation in the sciatic notch and along the sciatic nerve, impaired pain, temperature, and touch sensation in the L5S1 or L4-L5 dermatomes of the leg and foot, decreased or absent ankle jerk reflex, and mild weakness of the foot. More rarely, there is development of cauda equina syndrome, saddle anesthesia, decreased or absent reflexes in the lower extremities, and neurogenic bowel or bladder dysfunction. So again, here you're taking a look at the sensory nerve distribution of skin dermatomes. With the herniation of a lower cervical disc, paresthesias and pain are present in the upper arm, forearm, and hand in the affected nerve root distribution. Neck motion and straining, including coughing and sneezing, may increase neck and nerve root pain. Neck range of motion is diminished. Slight weakness and atrophy of biceps or triceps may occur. The biceps or triceps reflex may decrease. Occasionally, signs of corticospinal and sensory tract impairments appear. These include motor weakness of the lower extremities, sensory disturbances in the lower extremities, and presence of a Babinski reflex. Your evaluation and treatment. Diagnosis of a herniated intervertebral disc is made through the history and physical exam, spinal X-ray films, electromyelography, CT scans, MRIs, myelography, discography, and nerve conduction studies. Evidence-based practice guidelines have been published to guide treatment options. Most herniated discs heal spontaneously over time and do not require surgery. A surgical approach is indicated if there is evidence of severe compression, or if the conservative approach is unsuccessful. Cauda equina syndrome requires emergency surgical evaluations. So that leads us to cerebrovascular disorders. Cerebrovascular disease is the most frequently occurring neurologic disorder, accounting for more than 50% of people admitted to the general hospital with neurologic problems. Any abnormality of the brain caused by a pathologic process in the blood vessels is referred to as a cerebrovascular disease. Included in this category are lesions of the vessel wall, occlusion of the vessel lumen by thrombus or embolus, rupture of the vessel, and alterations in blood quality, such as an increased blood viscosity or clotting. The brain abnormalities induced by cerebrovascular disease are either ischemia with or without infarction or hemorrhage. The common clinical manifestation of cerebrovascular disease is a cerebrovascular accident or stroke. The symptoms occur suddenly and are usually focal: slurred speech, difficulty swallowing, limb weakness, or paralysis. In its mildest form, a cerebrovascular accident is so minimal that it is almost unnoticed. In its most severe form, hemiplegia, coma, and death is a result. So cerebrovascular accidents, your stroke syndromes. CVAs are the leading cause of disability, the third cause of death in women, and the fifth leading cause of death in men. About 75% of strokes occur among those older than 65 years of age. There has been a decline in ischemic strokes among whites, but not blacks. The yearly incidence of new and recurrent strokes is about 795,000 people. Approximately 185,000 of these are recurrent, and there is about 128,900 deaths per year, a decline of 18.2% from 2003 to 2013. The incidence of stroke is about 150% greater in blacks than whites. Stroke tends to run in families. Of all strokes, 87% are ischemic, 10% are intracerebral hemorrhages, and 3% are subarachnoid hemorrhages. Strokes in children, as discussed in Chapter 20. Cerebrovascular accidents are classified pathophysiologic as ischemic, hemorrhagic, or cryotogenic. If no identifiable cause can be established by conventional diagnostic tests in ischemic strokes, they are classified as undetermined or cryptogenic. Risk factors for stroke include the following: poorly or uncontrolled arterial hypertension, smoking, insulin resistance and diabetes, polycythemia and thrombocytopenia, high cholesterol or low high-density lipoprotein cholesterol, congenital heart disease, peripheral vascular disease, hyperhomocysteemia, AFib, physical inactivity, family history and genetics, sleep apnea, chlamydia pneumonia infections, sickle cell disease, postmenopausal hormone therapy, high sodium intake or low potassium intake, obesity, and depression. So let's talk about ischemic strokes. Ischemic strokes occur when there is an obstruction to arterial blood flow to the brain from thrombus formation, an embolus associated with atherosclerosis, or hypoperfusion related to decreased blood volume or heart failure. The inadequate blood supply results in ischemia and can progress to infarction. Your transient ischemic attacks, or TIAs, are episodes of neurologic dysfunction lasting no more than 1 hour and resulting from focal cerebral ischemia. The clinical manifestations of a TIA may include weakness, numbness, sudden confusion, loss of balance, loss of vision, or sudden severe headache. Resulting from focal cerebral ischemia, the use of brain imaging modalities often reveal a brain infarction. About 3 to 17% of individuals experiencing a TIA will have a stroke within 90 days. Risk stratification for early stroke is enhanced when imaging is combined with risk stratification scores, which consider age, blood pressure, neurologic symptoms, symptom duration, and diabetes. Guidelines are available for the prevention of future strokes. Thrombotic strokes arise from arterial occlusions caused by thrombus formation in large or small arteries supplying the brain or intracranial vessels. Conditions causing increased coagulation or inadequate cerebral perfusion increase the risk of thrombosis. Cerebral thrombosis develops most often from atherosclerosis and inflammatory disease processes that damage arterial walls. It may take as long as 20 to 30 years for obstruction to develop at the branches and curvature found in the cerebral circulation. The smooth stenotic area can degenerate, forming an ulcerated area of vessel wall. Platelets and fibrin adhere to the damaged wall, and clots form, gradually occluding the artery. The thrombus may enlarge both distally and proximally in the vessel. Thrombotic strokes occur when portions of clot detach, travel upstream, and obstruct blood flow, causing acute ischemia. Embolic strokes involves fragments that break from a thrombus formed outside the brain, usually in the heart, aorta, or common carotid artery. Other sources of embolism include fat, air, tumor, bacterial clumps, and foreign bodies. The embolus usually involves small brain vessels and obstructs at a bifurcation or other point of narrowing, thus causing ischemia. An embolus may obstruct the lumen entirely and remain in place or shatter into fragments and become part of the vessel's blood flow. Risk factors for an embolic stroke are AFib, left ventricular aneurysm or thrombus, left atrial thrombus, recent myocardial infarction, rheumatic valvular disease, mechanic prosthetic valve, non-bacterial thrombotic endocarditis, bacterial endocarditis, patent foramen ovale, and primary intracardiac tumors. In people who experience an embolic stroke, a second stroke usually follows at some point because the source of emboli continue to exist. Embolization is usually in the distribution of the middle cerebral artery. Ischemic strokes in children are associated with congenital heart disease, cerebral arteriovenous malformation, and sickle cell disease. Lacunar strokes are usually caused by perivascular edema, thickening, and inflammation of the arteriolar wall in a deep perforating artery that supplies small penetrating subcortical vessels. The ischemic lesions, or lacunes, are predominantly in the basal ganglia, internal capsules and pons. They are associated with hyperlipidemia, smoking, hypertension, and diabetes mellitus. These strokes represent about 25% of ischemic strokes, and because of the location of the small area of infarction, may have pure motor or sensory deficits. Hemodynamic stroke is associated with systemic hypoperfusion caused by cardiac failure, pulmonary emboli, or bleeding that result in inadequate blood supply to the brain. Stroke may occur more readily if there is carotid artery occlusion. Symptoms usually are bilateral and diffuse. Pathophysiology. Cerebral infarction results when an area of the brain loses its blood supply because of vascular occlusion. Causes include abrupt vascular occlusion, gradual vessel occlusion, and vessels that are stenosed, but not completely occluded. Cerebral thrombi and cerebral emboli most commonly produce occlusions, but atherosclerosis and hypotension are the dominant underlying process. There is a central core of irreversible ischemia and necrosis, or cerebral infarction. The central core is surrounded by a zone of borderline ischemic tissue, the ischemic penumbra. Ischemia in the penumbra is not severe enough to result in structural damage. Prompt restoration of perfusion in the penumbra by injection of thrombolytic agents promotes perfusion and may prevent necrosis and loss of neurologic function. The window of opportunity for protecting the penumbra is about 3 hours. Cerebral infarctions are ischemic or hemorrhagic. In ischemic infarcts, the affected area becomes pale and softens 6 to 12 hours after the occlusion, a white infarct. Necrosis, swelling around the insult, and mushy disintegration appears 48 to 72 hours after the infarction. There is infiltration of macrophages and phagocytosis of necrotic tissue. The necrosis resolves by about the second week, ultimately leaving a cavity surrounded by glial scarring. After occlusion of the cerebral artery, anastomosis connecting the distal segment of the middle cerebral artery with distal branches of the anterior and posterior cerebral arteries can partially maintain blood flow in the ischemic penumbra and delay or prevent cell death in some individuals. Vascular remodeling can occur with new arterioles sprouting from penumbra vessels that penetrate the ischemic core to reestablish collateral circulation. Efforts are in progress to enhance and promote collateral circulation following acute ischemic stroke. In hemorrhagic infarcts, bleeding occurs into the infarcted area through leaking vessels. When the embolic fragments resolve and reperfusion begins to occur, hemorrhagic transformation of ischemic infarct may be exacerbated by thrombolytic therapy. Unfortunately, reperfusion can compromise recovery by accelerating the sequence of metabolically damaging events, including oxidative stress. So, clinical manifestations. Clinical manifestations of thrombotic or embolic ischemic stroke vary, depending on the distribution of the artery obstructed. Different sites of vessels obstruction create different occlusion syndromes. The following table summarizes the various stroke syndromes. Contralateral sensory and motor manifestations occur on the opposite side of the body from the location of the brain lesion because motor tracts originate in the cortex and most cross over in the medulla. Sensory tracts originate in the periphery and cross over in the spinal cord. Ipsilateral manifestations occur on the same side as the brain lesion for tracts that do not cross over. So again, here's stroke syndrome secondary to occlusion or stenosis. The location, the area of the brain affected, and the signs and symptoms. So make sure you hit pause here. I know I kind of like clicked over that quickly, so make sure you hit pause so you can read all through that. Evaluation and treatment. Imaging is used to diagnose the different subtypes of ischemic strokes, your MRIs and CTs. Treatment of ischemic stroke is focused on restoring brain perfusion in a time frame that does not contribute to reperfusion injury, counteracting the ischemic cascade pathway, lowering cerebral metabolic demand so that the susceptible brain tissue is protected against impaired perfusion, preventing recurrent ischemic events, and promoting tissue restoration. Intravenous thrombolysis, given within 3 and up to 4.5 hours of onset of symptom, increases independent ambulation at 6 months when the diagnosis of ischemic stroke has been confirmed and contraindications are eliminated. Endovascular intraarterial thrombectomy can be used in combination with TPA or alone as an approach to endovascular reperfusion. Intracranial hemorrhage can be a complication of TPA administration. The American Heart Association and the American Stroke Association provide guidelines for the early management of acute ischemic strokes. Acute ischemic stroke frequency presents with hypertension, but the systemic blood pressure should not be treated unless the systolic pressure is 150 to 220 milligrams of mercury, or mean arterial pressure exceeds 150 milligrams of mercury. Overly aggressive treatment of hypertension can compromise collateral perfusion of the ischemic penumbra. When the pathophysiology of stroke is stabilized, all individuals should receive blood pressure lowering therapy to maintain a blood pressure lower than 140 over 90 milligrams of mercury, or 130 to 190 if there are comorbidities, such as diabetes or chronic kidney disease. Hypothermia has been used for neuroprotection in ischemic strokes for some promising results, but additional studies are needed to determine best methods and clinical practice guidelines. Neuroprotective agents have not been shown to significantly reduce the risk for poor outcome, including death with ischemic stroke. New neuroprotective agents are continuing to be evaluated for neuroprotection and to improve neuroplasticity and remodeling, including cell transplantation and neurostimulation. Arresting the disease process by control of risk factors is critical to prevention of stroke and to reduce associated morbidity and costs. Your hemorrhagic strokes is the third most common cause of stroke. Hemorrhagic stroke can occur within the brain tissue or in the subarachnoid or subdural space. The primary cause of intraparenchymal hemorrhagic stroke is hypertension, with other causes including tumors, coagulation disorders, trauma, or illicit drug use, particularly cocaine. Hypertensive causes of hemorrhagic stroke evolve over several years. They involve primarily smaller arteries and arterioles, resulting in thickening of the vessel wall and increased cellularity of the vessels. Necrosis may be present with vessel rupture. Microaneurysms in the smaller vessels of arteriolar necrosis may precipitate bleeding. Prevention or control of hypertension reduces the incidence of hemorrhagic stroke. Subarachnoid hemorrhage is associated with ruptured aneurysms, arteriovenous malformations, or cavernous angiomas or brain trauma. Subdural hemorrhage is usually associated with brain trauma. Pathophysiology. A mass of blood is formed as bleeding occurs in the brain tissue. Adjacent brain tissue is deformed, compressed, and displaced, producing ischemia, edema, increased ICP, and necrosis. Rupture or seepage of blood into the ventricular system often occurs and is associated with higher mortality. Hemorrhages are described as massive, small, slit, or petechial. Massive hemorrhages are several centimeters in diameter. Small hemorrhages are 1 to 2 centimeters in diameter. A slit hemorrhage occurs in small penetrating vessels in the subcortical area, leaving a slit-like cavity, and a petechial hemorrhage is the size of a pinhead. The most common sites for hypertensive hemorrhages are the putamen and the basal ganglia, the thalamus, the cortex and the subcortex, the pons, the caudate nucleus, and the cerebellar hemisphere. So here we're taking a look at hypertensive intracranial hemorrhage, or intracerebral hemorrhage rather. Because neurons surrounding the ischemic or infarcted area undergo changes that disrupt plasma membranes, cellular edema results, causing further compression of capillaries. In massive intracerebral hemorrhage, cerebral perfusion falls to zero and cerebral blood flow stops, resulting in death. In strokes with less than massive hemorrhage, adjacent brain tissue is displaced and compressed. Maximal cerebral edema develops in approximately 72 hours and takes about 2 weeks to subside. An inflammatory reaction in surrounding brain tissue appears rapidly and peaks in several days. The following illustrates additional detail. Most persons survive an initial hemispheric ischemic stroke, unless there is massive cerebral edema, which is nearly always fatal. The cerebral hemorrhage resolves through reabsorption, macrophages, and astrocytes that clear blood from the area, and a cavity forms surrounding the dense gliosis after the removal of the blood. So here you see the injury mechanism that promotes the intracerebral hemorrhage. So again, hit pause so you can take a look and see how that redistributes. Clinical manifestations of a hemorrhagic stroke are similar to those for embolic or thrombotic stroke and depend on the location and the size of the bleed. Once a deep, unresponsive state occurs, the immediate prognosis is great, and the individual rarely survives. If the person survives, however, recovery of function frequently is possible. Individuals experiencing intracranial hemorrhage from a ruptured or leaking aneurysm have one of three sets of symptoms. Onset of an excruciating generalized headache, with an almost immediate lapse into an unresponsive state. Headache, but with consciousness maintained and sudden lapse into unconsciousness. If the hemorrhage is confirmed to the subarachnoid space, there may be no local signs. If bleeding spreads into the brain tissue, hemiparesis, paralysis, dysphagia, or homonymous hemianopia may be present. Warning signs of an impending aneurysm rupture include headache, transient unilateral weakness, transient numbness and tingling, and transient speech disturbances. Such warning signs are often absent. So are evaluation and treatment. Clinical guidelines for the management of spontaneous intracerebral hemorrhage have been published by the American Heart Association and the American Stroke Association. Diagnosis of hemorrhagic stroke considers the healthy history, clinical presentation, lab tests, and neuroimaging, your CT and MRI. Treatment needs to be initiated within 3 to 4 hours of symptoms onset for reversibility of brain ischemia. Care in multidisciplinary stroke rehabilitation units appears to be the most effective at reducing disability, dependency, and length of hospital stay for all stroke syndromes. Treatment of a hemorrhagic stroke, regardless of cause, is focused on stopping or reducing the bleeding, controlling cerebral edema and increased intracranial pressure, preventing a rebleed, preventing vasospasms, and promoting tissue restoration and preventing or controlling seizures. Known coagulopathies should be corrected and oral anticoagulation reversed. Hypertensive and hypertension management is individualized. Elevated blood pressure can expand the hematoma, and low blood pressure can contribute to ischemia. Lowering systolic blood pressure is to no lower than 130 milligrams of mercury is probably beneficial but requires more evaluative studies. Intracranial hemorrhage and hemorrhagic transformation of ischemic strokes are risk factors for early seizures, and cortical involvement is associated with late seizures. Routine prophylactic treatment of seizure that may be associated with stroke is controversial and requires more investigation. Disruption of the blood-brain barrier results in cerebral edema and increased ICP. Osmotic therapies are used for treatment of increased ICP and cerebral edema and hemorrhagic strokes. Medical therapies to control clot expansion have not shown significant effects on improving mortality. There are some attempts to drain blood in a cerebral bleed, but the benefit is not documented in studies. Microsurgical interventions are under investigation. Surgical treatment are options for ruptured aneurysms, vascular malformations, and subarachnoid hemorrhages. Supportive care is provided for airway management, respiratory function, blood pressure control, avoidance of fever, and maintenance of fluids, glucose, electrolytes, and nutrients. Intracranial aneurysms. Intracranial aneurysms may result from arteriosclerosis, congenital abnormality, cocaine use, trauma, inflammation, and vascular shear wall stress. The size of the aneurysm may vary from 2 millimeters to 3 centimeters. Aneurysms may be a single, however, more than one is present in 20 to 25% of cases. The aneurysm may be unilateral or bilateral in these instances. Peak incidence of rupture occurs in people between the age of 50 to 59, with incidence of postmenopausal women slightly higher than men. Your pathophysiology. No single pathologic mechanism exists. A combination of genetic, congenital, and acquired factors is usually present. Abnormalities in multiple layers of the blood vessel are found. The endothelial layer is thin, the internal elastic lamina is not present or fragmented, and the muscularis layers of the media ends at the aneurysm. Inflammatory cells are recruited, reducing apoptosis and remodeling of the vascular wall. Atherosclerosis changes are found. Aneurysm development is attributed to hemodynamic and wall shear, stress and flow turbulence, particularly at bifurcations, such as in or near the circle of Willis. In the vertebrovascular arteries, or within the carotid artery system, they are symptoms of underlying vascular disease, hypertension, and certain connective tissue disorders in which there are abnormalities in the extracellular matrix exacerbate aneurysm formation. Aneurysms may be classified on the basis of the shape and form. So there's different types of aneurysms. Saccular aneurysm or berry aneurysm occur frequently in about 2% of the population and are the result of a combination of congenital abnormality in the media of the arterial wall with loss of smooth muscle cells, inflammation, thrombus formation, and degenerative changes. The sac expands over time. A saccular aneurysm may be round with a narrow stalk connecting to the parent artery, broad-based with a stalk, or cylindrical. Saccular aneurysms are rare in childhood. Their highest incidence of rupturing or bleeding is among people 20 to 50 years of age. So here you see the berry aneurysm. Fusiform aneurysm, or giant aneurysm, by definition greater than 25 millimeters in diameter, make up 5% of all intracranial aneurysms. They occur as a result of diffuse atherosclerotic changes and are found most common in the basilar arteries or a terminal portion of the internal carotid artery. They act as space-occupying lesions and often present as an ischemic stroke. Mycotic aneurysms are rare and result from arteries caused by bacterial emboli. These aneurysms are uncommon. Traumatic aneurysms are the weakening of the arterial wall caused by a fracture line, a penetrating missile, or after neurosurgical surgical or imaging procedures. What causes an aneurysm to rupture is not known. Aneurysm rupture through thin areas, often at bifurcation sites, and cause hemorrhage into subarachnoid space, with rapid spread producing localized changes in the cerebral cortex and focal irritation of nerves and arteries. Because of compression, bleeding ceases with the formation of fibrin platelet plug at the point of rupture. Blood undergoes reabsorption through the arachnoid villi within 3 weeks. Clinical manifestations. Aneurysms are often asymptomatic. Of all persons undergoing routine autopsy, 5% are found to have one or more intracranial aneurysm. Clinical manifestations may arise from cranial nerve compression, but the signs vary depending on the location and the size of the aneurysm. Most often, cranial nerves 3, 4, 5, and 6 are affected. Unfortunately, the most common first indication is a ruptured aneurysm, causing acute subarachnoid hemorrhage, intracerebral hemorrhage, or combined subarachnoid intracerebral hemorrhage. So our evaluation and treatment. Diagnosis before a bleeding episode is made using arteriography. Intracranial aneurysms may be found incidentally during CT or MRI imaging. For other conditions, after a subarachnoid or an intracerebral hemorrhage, a tentative diagnosis of an aneurysm that has bled is based on clinical manifestation, history, and imaging. Modifiable risk factors include smoking, alcohol use, and hypertension. Treatment of intracranial aneurysm are both medical and surgical. The mortality rate following rupture is 50%, and 50% of survivors are disabled, often severely. Vascular malformations. Vascular malformations are rare, congenital vascular lesions that occur sporadically. An arteriovenous malformation, or AVM, is a mass of dilated vessels between the arterial and venous system that lack a muscularis layer and have the absence of an intervening capillary bed. They can cause hemorrhagic stroke, epilepsy, chronic headache, or focal neurologic deficits. Four types of vascular malformations exist: arteriovenous malformation, cavernous angioma, capillary telangiectasis, and venous angioma. They usually rupture in the second and third decade of life. Cavernous angiomas are rare, sinusoidal collections of blood vessels without interspersed normal brain tissue. They rarely hemorrhage and comprise 2 to 4% of hemorrhagic strokes. A capillary telangiectasis is dilated capillaries with interspersed normal brain tissue found deep in the brain, particularly in the brainstem. Hemorrhagic or hemorrhage is rare. These vascular malformations are associated with Rindu-Osler-Weber disease. Venous angioma, the most common vascular malformation found in autopsy, roughly 3% of cases, is considered a subset of developmental venous anomalies that occur secondary to arrested development. The result is primitive embryologic veins in a radical pattern feeding a central vein. These rarely hemorrhage. Pathophysiology. AVMs are developmental abnormalities that represent persistence of embryonic patterns of blood vessels. The vessels are abnormally thin and have complex growth and remodeling patterns. Their size is variable. The direct shunting of arterial blood into the venous vasculature without the dissipation of the arterial blood pressure increases risk for rupture. One of the several arteries may feed the AVM, and over time, they become tortuous and dilated. With moderate to large AVMs, sufficient blood is shunted into the malformation to deprive surrounding tissue of adequate blood perfusion. So here you're looking at the vascular malformation. Clinical manifestations. 20% of persons with an AVM have a characteristic chronic nondescript headache, although some experience migraines. 50% of persons experience seizures. The other 50% experience an intracerebral subarachnoid or subdural hemorrhage with progressive neurologic deficits. Bleeding from an AVM into the subarachnoid space causes clinical manifestations identical to those associated with a ruptured aneurysm. If bleeding is into the brain tissue, focal signs progress over a short period of time. 10% of persons experience hemiparesis or other focal signs. Hemiparesis usually is caused by compression or rupture. At times, non-communicating hydrocephalus develops with a large AVM that exceeds into the ventricle lining. AVM accounts for up to 1% of all sudden death. So your evaluation and treatment. A systolic bruit over the carotid in the neck and the mastoid process or in the eyeball is almost diagnostic of an AVM. Confirming diagnosis is made by a CAT scan and MRI, followed by a magnetic resonance angiography. Treatment options include direct surgical excision, endovascular embolization, or radiotherapy. So your subarachnoid hemorrhage. Subarachnoid hemorrhage is the escape of blood from the defective or injured vasculature into the subarachnoid space. Individuals at risk for SAH are those with intracranial aneurysm, intracranial arteriovenous malformation, hypertension, a family history of SAH, and those who have sustained head injuries. Subarachnoid hemorrhage often recur, especially from a ruptured intracranial aneurysm. Other risk factors include heavy alcohol use, smoking, anticoagulation use, and oral contraceptives. Mortality is approximately 50%, and about one-third of survivors require dependent care. SAH often recur, especially from a ruptured intracranial aneurysm. So what is the pathophysiology behind it? When a vessel is leaking, blood oozes into the subarachnoid space. When the vessel tears, blood under pressure is pumped into the subarachnoid space. The blood increases, the intracranial volume is extremely irritant to the meningeal and other neural tissues and produces an inflammatory reaction. Additionally, the blood coats nerve roots, clogs arachnoid granulations, and clogs foramina within the ventricular system. ICP immediately increases to almost diastolic levels. ICP returns to near baseline in about 10 minutes. Autoregulation of blood flow is impaired, and there is a compensatory increase in systolic blood pressure. The expanding hematoma acts like a space-occupying lesion, compression and displacing brain tissue with increased ICP. Decreased cerebral perfusion pressure, decreased cerebral blood flow, blood-brain barrier breakdown, brain edema, inflammation, and cell death. Secondary brain injury can occur as described for deep TBIs. Delayed cerebral ischemia, a syndrome of progressive neurologic deterioration, is associated with cerebral artery vasospasm. From 40 to 60% of persons with a subarachnoid hemorrhage experience vasospasms in adjacent and occasionally in non-adjacent vessels. Vasospasm may occur because of leukocyte endothelial cell interactions or the effects of inflammatory vasoactive substances on the arteries of the subarachnoid space. Edema, medial necrosis, and proliferation of the tunica intima have been found. Vasospasm causes decreased cerebral blood flow, ischemia, and possible infarct, and can lead to a delayed ischemic injury and death 3 to 14 days after the initial hemorrhage. So, clinical manifestations. Early manifestations associated with a leaking vessel are episodic and include headache, changes in mental status or level of consciousness, nausea, vomiting, and focal neurologic defects such as visual or speech disturbances, cranial nerve palsies, or stiff neck. A ruptured vessel causes a sudden throbbing, explosive headache accompanied by nausea and vomiting, visual disturbances, motor deficits, and loss of consciousness related to a dramatic rise in ICP. Meningeal irritation and inflammation often occur, causing neck stiffness, photophobia, blurred vision, irritability, restlessness, and low-grade fever. A positive Kernig's sign and a positive Brudzinski sign may appear. No localizing signs are present if the bleed is confined completely to the subarachnoid space. Hyponatremia is common and related to cerebral salt wasting or syndrome of inappropriate antidiuretic hormone. Several scales have been developed for grading SAH. One of the most commonly used is the Hunt and Hess grading system combined with GCS. The Hunt and Hess SAH grading system is based on the description of the clinical manifestation in Table 18.6. Rebleeding is a significant risk with a high mortality, up to 70%. The period of greatest risk is the first 6 hours after an SAH is association with high systolic blood pressure and higher Hunt and Hess grade, large-sized aneurysm, and large posterior hematoma. Rebleeding is manifested by a sudden increase in blood pressure and ICP, along with deteriorating neurologic status. So here's a table of the subarachnoid hemorrhage classification scale. Hit pause so you can take a look at it if you're unfamiliar with it. Seizures occur in 25% of persons with SAH. Granulation tissue is formed and scarring of the meninges with resulting impairment of the CSF reabsorption leads to secondary hydrocephalus in about 20% of cases. Hypothalamic dysfunction, manifested by salt wasting, hyponatremia, and EKG changes is common. So are evaluation and treatment. The diagnosis of SAH is based on the clinical presentation and proving the CSF evaluation. Treatment is directed at controlling ICP, improving cerebral perfusion pressure, preventing ischemia and hypoxia of neural tissue, and avoiding rebleeding episodes. Surgical intervention is common, including surgical clipping of the aneurysm and endovascular placement of coils to occlude the aneurysm. Nimodipine, a calcium channel blocker, is used to prevent vasospasm, and magnesium phosphodiesterases, 3 inhibitors, and therapeutic hypothermia are being evaluated. Treatment guidelines are available to help direct therapy. Your primary headache. Headache is a common neurologic disorder and is usually a benign symptom. However, it can be associated with serious illness, such as brain tumor, meningitis, giant cell arteriitis, and cerebrovascular disease. The primary headache syndromes discussed here are the chronic, recurring type, not associated with structural abnormalities, or systemic disease, and include migraine, cluster, paroxysmal, hemicrania, and tension headaches. Characteristics of major types of headache syndromes are summarized in the following table. So again, hit pause so you can look at the differences between migraine with and without an aura, cluster headaches, and tension headaches. Here's a good spot to pause, and you can go ahead and review. Migraine. Migraine is an episodic neurologic disorder whose marker is headache lasting 4 to 72 hours. It is diagnosed when any 2 of the following features occur: unilateral head pain, throbbing pain, pain worsening with activity, moderate or severe pain intensity, and at least one of the following: nausea and or vomiting, photophobia, and phenophobia. Migraine is broadly classified as migraine with aura, with visual, sensory, and motor symptoms, and more commonly, migraine without aura, and chronic migraine. Migraine occurs in about 18% of women, 6% of men, and 10% of children in the US. It is common in those 25 to 55 years of age. There often is a family history of migraine. In susceptible women, migraine occurs most frequently before and during menstruation and is decreased during pregnancy and menopause. The cyclic withdrawal of estrogen and progesterone may trigger attacks of migraine. Migraine is caused by a combination of multiple genetic and environmental factors. Persons with migraine have an increased risk for epilepsy, depression, anxiety disorder, cardiovascular disease, and ischemic stroke. Migraine may be precipitated by triggers. Individuals with migraine are likely to have a genetically determined reduced threshold for triggers. Triggers can include endogenous factors. The pathophysiologic basis for migraine is complex and not clearly established. There is no identifiable pathology, but there are associated changes in brain metabolism and blood flow. Current theories include neurologic, vascular, hormonal, and neurotransmitter components. Migraine aura is associated with cortical spreading depression. CSD is a spontaneous, self-propagating wave of glial and neuronal depolarization, resulting in hyperactivity that starts in the occipital region and spreads across the cortex. CSD initiates the headache phase with release of neurotransmitters that activate the trigeminal vascular system, stimulating vasodilation of the dural blood vessels, activation of inflammation, peripheral and central sensitization of pain receptors, and activation of areas of the brainstem and forebrain that modulate pain. Release of inflammatory mediators with sterile meningeal inflammation and edema of blood vessels may be an important component of migraine pain. Vasodilation of blood vessels is not sufficient to account for the pain of migraine. Calcitonin gene-related peptase or peptide released by the trigeminal vascular system is related to migraine pain. The mechanism is not clear, but CGRP antagonists prevent the headache. Glutamate concentration is increased, and 5-hydroxytryptamine concentration is decreased. 5-HT causes vasoconstriction and antagonizes CGRP. Consequently, 5-HT receptor agonists and CGRP receptor and glutamate receptor antagonists have been used for the acute treatment of severe migraines. The clinical phase of a migraine attack are as follows. Premonitory phase. Up to 1/3 of a person have premonitory symptoms, hours to days before onset of aura or headache. These symptoms include tiredness, irritability, loss of concentration, stiff neck, and food cravings. Migraine aura. Up to 1/3 of persons have aura symptoms, at least some of the time, that may last up to 1 hour. Symptoms can be visual, sensory, or motor. There are no associated focal neurologic symptoms in migraine without aura. Headache phase. Throbbing pain usually begins on one side and spreads to include the entire head. Headache may be accompanied by fatigue, nausea, and vomiting, or dizziness. There may be hypersensitivity to anything touching the head. Symptoms may last from 4 to 72 hours. The recovery phase. Irritability, fatigue, or depression may take hours or days to resolve. The diagnosis of migraine is made from medical history and physical examination. Differential diagnosis is confirmed by imaging and EEG. Functional neuroimaging and genetic studies are advancing the understanding of the mechanism involved in migraine attacks and the individual variants involved with disease susceptibility. The management of migraine include avoidance of triggers. Sleeping can provide some relief with the onset of acute migraine. Pharmacologic management for the treatment and prevention of migraine is available and individualized. A transcutaneous electrical stimulation device providing trigeminal neurostimulation has been approved by the Food and Drug Administration for the prevention of migraines. Chronic migraines usually begin as episodic migraines that increase in frequency over time. Chronic migraine occur at least 15 days in a month for more than 3 months. Chronic migraines are associated with overuse of analgesic migraine medication, obesity, and caffeine overuse. Treatment is similar to that for episodic migraine. Injections with botulinum toxin A are approved for preventing chronic migraines. Individuals with chronic migraine unresponsive to medical treatment should be evaluated for intracranial hypertension without papilledema and the possibility of sinus venous stenosis. Your cluster headache. Cluster headaches are one of the group of rare disorders referred to as trigeminal autonomic cephalgia. They occur on one side of the head, primarily in men between 20 and 50 years of age. The pain may alternate sides with each headache episode and is severe, stabbing and throbbing. These uncommon headaches occur in clusters and last from minutes to hours for a period of days, followed by a long period of spontaneous remission. Cluster headaches has an episodic and a chronic form with extreme pain intensity and short duration. If the cluster of attacks occurs more frequently without sustained spontaneous remission, they are classified as a chronic cluster headache. Triggers are similar to those that cause migraine headaches. Trigeminal activation occurs, but the mechanism is unclear. Functional imaging indicates a role for concomitant posterior hypothalamic and pain neuromatrix activation with opioid system involvement. The pathogenic mechanism for pain is related to the release of vasoactive peptides and the formation of neurogenic inflammation. Autonomic dysfunction is characterized by sympathetic underactivity and parasympathetic activation. The headache attack usually begins without warning. There is unilateral trigeminal distribution of severe pain with ipsilateral autonomic manifestation, including tearing on the affected side, ptosis of the ipsilateral eye, and congestion of the nasal mucosa. Pain often is referred to the midface and teeth. Prophylactic drugs and avoidance of triggers are used to treat cluster headaches. Acute attacks are managed with oxygen inhalation, sumatriptan, or inhaled ergotamine administration and nerve stimulation. New drugs are under investigation. Chronic paroxysmal hemicrania is a cluster-type headache with unilateral head pain associated with autonomic features that occur with more daily frequency, but with shorter duration. The remission phase are often shorter. The attacks occur in men and women beginning at 30 to 40 years of age. The symptoms are similar to cluster headaches. As with cluster headaches, there is an episodic and a chronic form. The pathophysiology involves a disorder of sympathetic hyperactivity, but the mechanism is different from that of cluster headache because there is effective relief of symptoms with indomethacin. That leads us to a tension type headache. Tension type headache is the most prevalent type of recurrent headache. It is not a vascular or migraneous headache. The average age of onset is during the second decade of life. It is usually a mild to moderate bilateral headache with a sensation of a tight band or pressure around the head. The onset of pain is usually gradual. Episodic tension type headache occurs less than 15 days per month and may last for several hours or several days. It is not aggravated by physical activity and may be triggered by sleep disorders. Chronic tension headaches evolve from episodic tension type headaches, or TTH, and occur at least 15 days per month for at least 3 months. Many individuals have both tension type and migraine headaches. Both central and peripheral mechanisms operate in causing tension headache. The central mechanism probably involves hypersensitivity of pain fibers from the trigeminal nerve that leads to central sensitization with deficits in the descending inhibitory pain pathway within the brainstem. The peripheral sensitization of myofascial sensory afferents may contribute to muscular hypersensitivity and the development of chronic TTH. Headache sufferers have more localized pain and tenderness of pericranial muscles. Mild headaches are treated with ice, and more severe forms are treated with aspirin or other nonsteroidal anti-inflammatory drugs. Chronic TTHs are best managed with a tricyclic antidepressant and behavior and relaxation therapy. Some individuals benefit from injection of botulinum toxin. A. Long-term use of analgesics or other drugs such as muscle relaxants, antihistamines, tranquilizers, caffeine, and ergoalkaloids should be avoided. So, now we have the infection and inflammation of the central nervous system. The CNS may be infected by bacteria, viruses, fungi, parasites, and mycobacteria. The infecting microorganisms gain entry to the nervous system by spreading through arterial blood vessels or direct extension from another site of infection. Neurologic infections produce disease by several mechanisms: direct neuronal or glial infection, mass lesion formation, inflammation with subsequent edema, interruption of CSF pathways, neuronal or vascular damage, and secretion of neurotoxins. An immune process initiates an inflammatory reaction. Syndromes are acute or subacute bacterial meningitis, epidural and brain abscesses, encephalitis, peripheral neuropathy, or neurosyphilis, depending on the infecting microorganism. Signs and symptoms are produced because of interference with the function of the nervous system, tissue being invaded or compressed, or the inflammatory response produced by the body in response to infection. The cardinal signs of CNS infection are fever, head or spine pain, and generalized or focal neurologic dysfunction. So, meningitis. Meningitis is the inflammation of the brain or spinal cord. Infectious meningitis may be caused by bacteria, viruses, fungi, parasites, or toxins. The infection may be acute, subacute, or chronic, with pathophysiology, clinical manifestations, and treatment differing for each type of microorganism. Bacterial meningitis is primarily an infection of the pia mater and arachnoid villi, the subarachnoid space, the ventricular system, and the CSF. There's roughly 5 to 10 cases per 100,000 annually. Meningococcus and pneumococcus are the most common pathogens. An increase of drug-resistant strains of S. pneumoniae is an emerging problem worldwide. Meningococcus has been identified worldwide, and there are 6 serogroups: A, B, C, W135, X, and Y. Most cases are sporadic and occur predominantly in children younger than 1 year of age and adolescents. Local outbreaks may occur in dormitories, military bases, or sub-Saharan Africa. Young people and those more than 40 years of age are mostly affected by pneumococcal meningitis. Predisposing conditions are otitis or sinusitis, immunocompromised status, and pneumonia. The disease is spread by respiratory droplets and contact with contaminated saliva or respiratory tract secretions, kissing, coughing, sneezing, sharing utensils, sharing food or drinks. Carriers of meningococcal bacteria do not develop meningitis but may pass it on to others. Bacterial meningococci and pneumococci are inhaled and attached to epithelial cells in the nasopharynx, where they evade immune defenses, cross the mucosal barrier, enter the bloodstream, travel to the cerebral blood vessel, cross the blood-brain barrier, and infect the meninges. Bacteria multiply in the subarachnoid space and attract large number of neutrophils, release of cytotoxic inflammatory agents, and bacterial endotoxins, all to the blood-brain barrier, cause cerebral edema, and damage brain tissue. The inflammatory exudate thickens the CSF and interferes with normal CSF flow around the brain and spinal cord, possibly obstructing arachnoid villi and producing hydrocephalus. Meningeal cells become edematous, and the combined exudate and endematous cells increase ICP. Engorged blood vessels and thrombi can disrupt blood flow, causing further injury. The cortical neurons also show some changes, including an increase in the number of micralgia and astrocytes. Acute infectious purpura fulminans is a rare, rapidly progressive syndrome of hemorrhagic infarction of the skin and disseminating intravascular coagulation that can lead to multiple organ failure, ischemic necrosis of digits and limbs with amputation required, and death. It is caused by bacterial endotoxins and inflammatory cytokines with meningitis. So here we see how meningitis works. So go ahead and hit pause here so you can read through the process. So here we're looking at acute bacterial leptomeningitis. The clinical manifestations of bacterial meningitis can be grouped into infectious signs, meningeal inflammatory signs, and neurologic signs. The clinical manifestations of systemic infection include fever, tachycardia, and chills. The clinical manifestations of meningeal irritation are a severe throbbing headache, severe photophobia, nuchal rigidity, and positive Kernick and Brudzinski signs. The neurologic signs include a decrease in consciousness, focal neurologic deficits, and seizures. The irritation and damage to the cranial nerve produced by the inflamed sheaths manifest as following: cranial nerve 2, papilledema and blindness; cranial nerves 3, 4, and 6 as ptosis, visual field deficits, and diplopia; cranial nerve 5, photophobia; cranial nerve 7, facial paresis; and cranial nerve 8, deafness, tinnitus, and vertigo. Neck stiffness and pain, and possibly head retraction, reflect the irritability of spinal accessory and cervical spine nerves. Often, the vomiting center is irritated, causing projectile vomiting. Confusion and decreasing responsiveness are evidence of cortical involvement. In meningococcal meningitis, petechial or purpurish rash involving the skin and mucous membranes occurs. As ICP increases, papilledema may develop with declining levels of consciousness. Rapid diagnosis, antibiotic administration, and supportive treatment are important to prevent morbidity and mortality from bacterial meningitis. Dexamethasone therapy has been implemented as adjunctive treatment of adults with pneumococcal meningitis. Diagnosis is based on physical exam, blood culture, and results of the nasopharyngeal smear and antigen test. CSF analysis and culture are required to diagnose fungal meningitis. Other supportive measures may be needed. Serious complications include septic shock, disseminating intravascular coagulation, purpura fulminans, and multiple organ failure. Require intensive multidisciplinary care. Vaccination are available to prevent meningococcal, pneumococcal, and Haemophilus influenza meningitis. So viral meningitis. Viral meningitis is believed to be limited to the meninges, and an identifiable bacterium or specific pathogen cannot be found in the CSF. The most at-risk population and the time of year when occurrences are seen depends on the virus and on the immune system and status of the individual. Viral meningitis produces a variety of symptoms and is caused by a variety of viruses. Viruses infecting specific cell types are presented in Figure 18.26. Viruses causing acute and chronic CNS infections are listed in Table 18.8. So here we see the viral infection of specific cells in the central nervous system. Again, hit pause if you need to review the anatomy of how viruses work. And here on this table are viruses that cause acute and chronic CNS diseases. So again, a good spot to hit pause so you can see, excuse me, so you can see the differences in different viruses. Trying to keep as many on one spot as possible. There you go. So here's another good spot to hit pause. Again, make flashcards, things like that help you remember these things. In viral meningitis, the virus reaches the CNS by hematogenous spread. The virus enters the brain either directly or indirectly. through infected migrating leukocytes and then infects vascular endothelial cells. The virus then enters the subarachnoid space, leading to meningitis. The immune response leads to release of inflammatory cytokines, with increased permeability of the blood-brain barrier and entry of circulating immunoglobulins that combat the virus. So here we see the hematogenous spread of the viral pathogen to the central nervous system. The clinical manifestations of viral meningitis are mild compared to those associated with bacterial meningitis. Mild generalized throbbing headache, mild photophobia, mild neck pain, stiffness, fever, and malaise are manifestations of viral meningitis. Treatment, primarily supportive, and the disease usually resolves within 7 to 10 days. A fungal meningitis. Fungal meningitis is a chronic condition that is much less common than bacterial or viral meningitis. The most common fungal infection of the nervous system are histoplasmosis, cryptococcosis, coccidiodiomycosis, mucormycosis, candidiasis, and aspergillus. It develops insidiously, usually over days or weeks. Fungi in the nervous system usually produce a granulomatous reaction with formation of granulomas or gelatinous masses. These usually develop in the meninges at the base of the brain. Fungi also may extend along the perivascular site in the subarachnoid space and into the brain tissue, producing arteriitis with thrombosis, infarction, and communicating hydrocephalus. Meningeal fibrosis develops later in the inflammatory process. Cranial nerve dysfunction, caused by compression, often results from the granulomas and fibrosis. The first manifestations are often those of dementia or communicating hydrocephalus. The individual is characteristically afebrile. Cryptococcal meningitis occurs in immunosuppressed hosts, including organ transplant recipients and individuals with HIV and AIDS. Candida and Aspergillus are less common infections. Antifungal treatment are organism-specific and effective. Tubercular meningitis. Tubercular meningitis is a common and serious form of a CNS tuberculosis, especially in the immunosuppressed individual or those with acquired immunodeficiency syndrome, AIDS. Mycobacteria are acquired through inhalation of aerosolized droplet nuclei. The miliary tubercles form in the brain and meninges. At some point, the tuberculomas erode the pia mater, and the mycobacteria enter the CSF, producing a hypersensitivity reaction that results in purulent exudate involving the basal meninges, cerebrum, and spinal nerves. Cerebral ischemia and infarction occur from vasculitis. Symptoms are nonspecific, making early diagnosis difficult. Symptoms include headache, low-grade fever, nausea, vomiting, irritability, difficulty sleeping, and fatigue. These signs and symptoms increase to confusion, stiff neck, significant behavioral changes, and seizures. Hydrocephalus and cranial nerve palsies or cerebral infarcts may occur. Recovery rate is 90% with early diagnosis and treatment with appropriate anti-tuberculosis therapy. Treatment is difficult in resource-poor countries. Brain or spinal cord abscess. Abscesses are localized collections of pus within the parenchyma of the brain or spinal cord and are rare. Immunosuppressed people are particularly at risk. Brain abscesses are classified as extradural, subdural, or intracerebral. Extradural brain abscesses are associated with osteomyelitis in a cranial bone. Subdural brain abscesses arise from a sinus infection or a vascular source. Intracerebral brain abscesses arise from a vascular source. Brain abscesses progress from localized inflammation to a necrotic core with the formation of a connective tissue capsule, usually within 14 days or longer. Existing abscesses also tend to spread and form daughter abscesses. Spinal cord abscesses are rare and classified as epidural or intramedullary. Epidural spinal abscesses usually originate as osteomyelitis in a vertebra or as a bacterial meningitis. The infection then spreads into the epidural space. So, pathophysiology. Microorganisms gain entrance to the CNS from adjacent sites by direct extension from trauma, mastoiditis, sinusitis, or dental infection. Blood vessels carry infective emboli from distant sites, such as the heart, lungs, pelvic organs, skin, tonsils, abscessed teeth, osteomyelitis, and dirty needles. Streptococci, staphylococci, and bacteroides, often in combination with anaerobes, are the most common bacteria that cause abscesses. However, yeast and fungi also have been found in CNS abscesses. Toxoplasma gondii is producing an ever-increasing number of CNS abscesses in persons with AIDS. Most CNS abscesses are located in the frontal and temporal lobes. So here you're taking a look at a brain abscess. Brain abscesses evolve through 4 stages, regardless of infecting microorganism, except in the immunosuppressed host, where the process may be incomplete. The stages are ever as follows. Early cerebritis, a localized inflammatory process, develops in which perivascular infiltration and inflammatory cells, composed of neutrophils, plasma cells, and mononuclear cells, surround a central core of coagulative necrosis. Marked cerebral edema surrounds the area. Late cerebritis, days 4 through 9. The necrotic center is surrounded by an inflammatory infiltrate of macrophages and fibroblasts. Rapid new blood vessels form around the abscess. A thin capsule of fibroblasts and reticular fibers gradually develop, the area still surrounded by cerebral edema. Then stage 3, early capsule formation on days 10 through 13. The necrotic center decreases in size, the inflammatory infiltrate changes in character, and contains an increasing number of fibroblasts and macrophages. Mature collagen evolves, forming a capsule. And then 4. Late capsule formation, days 14 and longer. A well-formed necrotic center surrounded by a dense collagenous capsule starts to develop. So clinical manifestations. Early manifestations include a low-grade fever, headache, nausea, vomiting, neck pain, and stiffness, confusion, drowsiness, sensory deficits, and communication deficits. Later, manifestations are associated with an expanding mass and include decreased attention span, memory deficits, decreased visual acuity, and narrowed visual fields, papilledema, ocular palsy, ataxia, cognitive deficits, and seizures. The development of symptoms may be very insidious, often making an abscess difficult to diagnose. Contradural brain abscesses are associated with localized pain, purulent drainage from the nasal passage or auditory canal, fever, localized tenderness, and neck stiffness. Occasionally, the individual experiences a focal seizure. Clinical manifestations of spinal cord abscesses have 4 stages: spinal aching, root pain, which usually severe, accompanied by spasms of back muscles and limited vertebral movement because of pain and spasm. Weakness caused by progressive cord compression and paralysis. are evaluation and treatment, therefore. Diagnosis is suggested on the basis of clinical features and confirmed with MRI or a contrast-enhanced CAT scan. Stereotactic surgical aspiration is usually indicated for identification of the pathogen and for decompression of the abscess. Antibiotics are initiated when there is clinical suspicion of an abscess. Multiple or surgical inaccessible abscesses are treated with antibiotics, often in conjunction with corticosteroid therapy, to treat the cerebral edema. In addition, ICP or hydrocephalus, or both, require management. Because decompression is necessary, spinal cord abscesses are treated with surgical excision or aspiration. Antibiotic administration and supportive therapy are instituted. That leads us now to encephalitis. Encephalitis is an acute febrile illness, usually of viral origin, with nervous system involvement. The most common form are caused by bites of mosquitoes, ticks, or flies. Herpes simplex 1 is the most common sporadic cause of encephalitis. Etiologic agents for viral encephalitis are present in Table 18.8, referred to as infectious viral encephalitis. Encephalitis also may occur as a complication of a systemic viral disease, such as poliomyelitis, rabies, mononucleosis, rubella, or rubeola. Encephalitis also may follow vaccination with a live attenuated virus vaccine if the vaccine has encephalitis components, such as vaccines including the measles, mumps, rubella, varicella, rotavirus, and yellow fever. Typhus, trichinosis, malaria, and schistosomiasis also are associated with encephalitis. Toxoplasmosis may acutely reactivate in immunosuppressed hosts when the once dormant parasite in cyst form disseminates in brain tissue. With the exception of the California viral encephalitis, which is endemic, the arthropod-borne encephalitis occur in epidemics, varying in geographic and seasonal incidence. Eastern equine encephalitis is the most serious but least common of the encephalitis. West Nile virus is presented in box 18.1. So here are some classifications and characteristics of arthropod-borne viruses. Again, this is where it'll show that my PDF slides is a little incomplete as this little last section is cut off. And then some information on West Nile virus. Again, pause if you need it. The pathophysiology. Viruses gain access to the CNS through the bloodstream, olfactory bulb, or choroid plexus, or through an intraneural route from peripheral nerves. Meningeal involvement is present in all encephalitis. The arthropod-borne viral encephalitis cause widespread nerve cell degeneration. Edema and areas of necrosis with or without hemorrhage develop. Increased ICP develops and may progress to herniation. Large degenerative injuries are found in Eastern equine encephalitis, whereas the other arthropod-borne viral encephalitis have microscopic areas of injury and degeneration. Infectious encephalitis may result from a post-infectious autoimmune response to the virus or from direct invasion of the CNS by the virus. Herpes simplex type 1 has a tendency to infect the inferomedial surfaces of the temporal and frontal lobes and cause hemorrhagic necrosis. Clinical manifestations. Encephalitis may range from a mild infectious disease to a life-threatening disorder. The dramatic clinical manifestations of encephalitis are fever, altered mental status, delirium, or confusion, progressing to unconsciousness, seizure activity, cranial nerve palsies, paresis, or paralysis, involuntary movement, and abnormal reflexes. Signs of marked increased cranial pressure may be present. So our evaluation and treatment. Diagnosis is based on health history and clinical presentation, aided by CSF examination and culture. Serologic examination, white blood cell count, CT scans, and MRIs. Antiviral or immune therapy is initiated, as well as supportive therapy for cerebral edema, status epilepticus, and thrombocytopenia. Neurologic complications of acquired immunodeficiency syndrome. Roughly 40 to 60% of all people with AIDS have neurologic complications. On postmortem exam, 75% have nervous system pathologic findings. The CNS pathologic findings result from the primary human HIV infection, which seeds the CNS soon after primary infection when CD4 T cells are depressed. The immune dysregulation of early HIV infection and progressive immunosuppression in late HIV infections results in opportunistic infections, neoplasms, and systemic illness, and the complications of therapy. So, HIV-associated neurocognitive disorders, or HANDS. A variety of names have been used for HIV-associated neurocognitive disorders. HANDS, including HIV-associated dementia, associated cognitive dysfunction, encephalopathy, subacute encephalitis, associated dementia complex, cognitive motor complex, encephalopathy, dementia complex, and related dementia. Both adults and children may be affected with progressive cognitive dysfunction in conjunction with the motor and behavioral alterations. The syndrome typically develops later in the disease, but may be an early or an singular manifestation. The syndrome is more prevalent in drug users with HIV and among those with reduced highly active antiretroviral therapy adherence, HART. HART is more efficient. CNS drug penetration has reduced the prevalence and improved survival for severe hand, but milder forms of the disease persist because of a longer life. The neurologic syndromes develop from proprieties of the virus, genetic characteristics of the host, and interactions with the environment. At the time of primary HIV infection, HIV infects the perivascular macrophages, microglial cells, and astrocytes, particularly in the basal ganglia and deep white matter. Affected macrophages, macrophage-derived multinucleated cells, and microglia cause an immune-mediated demyelation process in the white matter. Focal and diffuse demyelination of white matter and spongy changes of the spinal cord are present. HAND is an insidious in onset and unpredictable in its course. Most individuals experience a steady progression of mental decline characterized by abrupt acceleration of signs over several months to more than 1 year. Although some experience an abrupt onset or an accelerated course, the triad of clinical manifestations are neurocognitive impairments, behavioral disturbances, and motor abnormalities. Clinical manifestations are summarized here in this box. So again, stop to see the early stages versus the advanced stages. Diagnosis is difficult, especially in early stages. The individual's health history, along with the physical exam findings and supporting CSF analysis, CAT scan, and MRI data, help establish the diagnosis. Although the brain may appear normal until there is advanced disease, research is continuing to evaluate the best treatment protocols and the possible neurotoxicity of heart. Your HIV myelopathy. HIV myelopathy involving diffuse degeneration of the spinal cord may occur with HIV. Vacuolar myelopathy is believed to be the direct consequence of HIV. The lateral and posterior columns of the lumbar spinal cord are affected. A progressive spastic paraparesis with ataxia is the predominant clinical manifestation. Leg weakness, upper motor neuron signs, incontinence, and posterior column sensory loss may be present. Diagnosis is made on the basis of history, physical findings, and supporting data from diagnostic procedures. Vacuolar myelopathy is treated supportively and does not respond to antiretrovirals. HIV-associated peripheral neuropathy. Some HIV-associated peripheral neuropathies occur early, may coincide with seroconversion, are immune-mediated, and respond to standard immunotherapies. Other peripheral neuropathies primarily develop with advanced HIV infection and immunocompromised states, and are facilitated by HIV replication, neurotoxicity from antiretroviral therapies, and co-infection with opportunistic pathogens. HIV neuropathy may have one or a combination of several presentations. A predominantly sensory neuropathy, an autonomic neuropathy, a mononeuritis, multicomplex, an inflammatory demyelinating polyneuropathy, such as Guillain-Barré, and a myopathy. The peripheral nervous system may sustain injury in HIV, manifesting as a peripheral neuropathy or radiculopathy. A progressive radiculopathy of predominantly the dorsal roots of the lumbar and sacral nerves may occur, involving severe myelin and axonal loss. HIV-associated distal symmetric polyneuropathy, a sensory neuropathy occurring late in the disease, is the most commonly occurring neuropathy, with slowly progressive numbness and paresthesias and a burning sensation in the extremities and feet. Weakness may be present. The distal reflex may be decreased or absent. The most common myopathy is the polymyositis. It may be present initially or develop later. Inflammation leads to muscle cell degeneration and necrosis, resulting in weakness of the extremities with myalgia and fatigue. HIV meningitis. Some people develop an acute viral meningitis at approximately the time of seroconversion. This may well represent the initial infection of the nervous system by HIV. Symptoms include headache, fever, and meningismus. Opportunistic infections in HIV. Opportunistic infections may be bacterial, fungal, protozoal, or viral in origin and produce nervous system disease. Cytomegalovirus encephalitis and tuberculosis meningitis have high incidence rates in African countries. Typically, bacterial infections are caused by unusual microorganisms. Cryptococcal infection is the most common fungal disorder and the most common cause of meningitis and HIV. In Cryptococcus neoformans, small granulomas and cysts are found in the cerebral cortex and later may be present in deep cerebral tissue. The symptoms are vague, such as fever, headache, malaise, and meningismus. Herpes encephalitis and herpes varicella zoster radiculitis may develop. Polyomavirus in the immunocompromised person with HIV may produce a demyelinating disorder called progressive multifocal leukoencephalopathy. The virus is found in 90% of healthy persons, but is dormant. The virus reactivates to cause PML in 50% of persons with HIV. Sensory and motor deficits, aphasia, and apraxia are common clinical manifestations. The condition is progressive, and there is no effective treatment. Toxoplasmosis is the most common opportunistic infection and occurs in one-third of persons with HIV. CNS toxoplasmosis typically manifests as focal encephalitis. Toxoplasma gondii, a protozoan, is thought to reactivate from latent lesion to produce a well-demarcated necrotizing process. Lesions may multiply and exist throughout the cerebral hemisphere. Clinical manifestations of CNS toxoplasmosis are focal, but highly variable and include clumsiness to hemiplegia, aphasia, seizure, ataxia, cognitive changes, and constitutional symptoms. Fever, headache, and confusion are common initial symptoms. Toxoplasmosis is difficult to diagnose, but is treated effectively with pyrimethamine, sulfadiazepine, plus leucovorin for 6 to 8 weeks. Your HIV-associated central nervous system neoplasms. HIV-associated CNS neoplasms have declined significantly with heart, particularly primary CNS lymphoma. Other neoplasms associated with HIV include systemic non-Hodgkin's lymphoma and metastatic Kaposi sarcoma. Metastasis of the Kaposi sarcoma to the CNS is uncommon, leading us to demyelinating disorders. Demyelinating disorders are the result of damage to the myelin nerve sheath and affect neural transmission. They can occur in either the central or the peripheral nervous system. Contributing factors include genetics, infection, autoimmune reactions, environmental toxins, and unknown factors. Multiple sclerosis. Multiple sclerosis is an inflammatory that is chronic. It is a disease involving degeneration of CNS myelin, scarring, and loss of axons. Multiple sclerosis is caused by an autoimmune response to self or microbial antigens in genetically susceptible individuals. The onset of MS is usually between 20 to 40 years of age and is more common in women. Men may have a more severe progressive course. The prevalence rate is higher in northern latitudes. Risk factors that may be involved include smoking, vitamin D deficiency, and Epstein-Barr virus infections. An estimated 2.3 million people worldwide live with MS. Life expectancy is not greatly altered by MS, and the disease course often extends over 30 years. The etiology of MS is currently unknown. The first demyelinating event, or clinically isolated syndrome, is a single episode of neurologic dysfunction lasting greater than 24 hours that can be a prelude to MS. Characteristic episodes include optic neuritis, solitary brainstem lesion, and transverse myelitis. Your pathophysiology. MS is a diffuse and progressive CNS inflammatory autoimmune disease that affects white and gray matter. Autoreactive T and B cells and macrophages breach the blood-brain barrier of the brain and spinal cord in association with upregulation of adhesion molecules and inflammatory cytokines. These cells recognize myelin autoantigens and produce myelin-specific antibodies, triggering inflammatory demyelination. There is subsequent loss of oligodendrocytes, and a hallmark plaque of MS is characterized by loss of myelin sheaths. Relative, relative preservation of axons and glial scar formation. Activated macrophages and microglial cells are found in active MS lesions. The loss of myelin disrupts nerve conduction, leading to symptom presentation. There is at least partial myelin repair during relapse of symptoms. There is ultimately death of neurons and brain atrophy in the most progressive forms of the disease. So here you see the pathogenesis of multiple sclerosis. Again, pause if you want to look at the anatomy behind it all. MS is characterized not only by the focal inflammatory changes, but also by diffuse injury throughout the CNS. MS lesions may occur anywhere in the white or gray matter. A paucity of immune cells and iron deposits are found, particularly in gray matter, and the pathologic significance may be associated with mitochondrial and oxidative injury. Researchers and research is in progress to determine if cerebral hypoperfusion is a pathogenic factor in MS. So here you see multiple sclerosis in the brain. Clinical manifestations, clinically isolated syndrome, an acute neurologic episode is the first manifestation of the disease. There is no evidence of previous episodes of demyelination. Symptoms last more than 24 hours, occur in the absence of fever, infection, or encephalopathy, and are caused by inflammation and demyelination in the CNS. Symptoms can be multifocal, including paresthesias of the face, trunk, or limbs, weakness, impaired gait, visual disturbances, or urinary incontinence, indicating diffuse CNS involvement. Monofocal symptoms are caused by a single lesion and include optic neuritis, spinal cord syndrome, and brainstem and cerebellar syndromes. Optic neuritis is a common presentation in one eye with progressive blurring of vision and pain with eye movement. Spinal cord syndrome can involve both sensory and motor tracts, starting on one side and progressing to the other. Brainstem syndromes can involve facial sensory loss or weakness, vertigo, or double vision. Cerebellar syndromes demonstrate lack of coordination, tremor, gait instability, and ataxia. Lesions in the cerebrum present as hemiphagia, weakness, pain, and motor impairments. Cognitive deficits, including memory and attention problems, are common later in the disease, as well as psychiatric disorders, depression, and dementia. Individuals with CIS may or may not progress to MS. MS is diagnosed by MRI-detected brain or spinal cord lesions. The initial syndrome depends on the portion of the CNS that is most involved. After years of disease, 50% of individuals appear to have established syndromes of multifocal involvement. The four symptoms subtypes of MS include a relapse remitting. This subtype is the most common type of MS and is characterized by relapses or exacerbations of previous symptoms or worsening of neurologic symptoms. After a relapse, a period of full or partial recovery lasts for days, weeks, or months. It is again more common in women. Primary progressive MS. This subtype is the least common and characterized by a gradual progression of the disease without periods of remission. Men and women seem to be equally affected, and the most common age of onset between the late 30s and early 40s. Disease activity is more prevalent in the spinal cord and is less likely than other forms to affect cognitive function. There is gradual loss of power in the limbs, or especially the lower limbs, that can be asymmetric in bowel and bladder symptoms. Symptom acuity has the potential to level off. Your secondary progressive MS. This subtype follows an initial period of relapsing remitting MS, followed by the gradual worsening of symptoms between relapses. Although there may be short intervals of symptom remission, these periods decrease over time and are often accompanied by more severe symptoms. And that leads us to the last one, progressive relapsing multiple sclerosis. This subtype is also characterized by steadily worsening symptoms from the onset with clear acute relapse, but often with more severe symptoms. So, evaluation and treatment. There is no single test available to diagnose or rule out MS, and many conditions can mimic MS clinically and radiologically, particularly early in the disease process. The diagnostic criteria for MS were revised in 2010 and are known as the McDonald criteria. The criteria include the clinical examination in combination with MRI to demonstrate MS lesion in time and space. MRI is the most sensitive and available method of detecting demyelinated plaques and monitoring the disease. Looking at Table 1810 and quantifying macrophage infiltration and abnormal iron deposits. Evoked potential testing aids diagnosis by detecting decreased conduction velocity in visual, auditory, and somatosensory pathways. Further studies are needed to confirm the diagnostic value of CSF findings. Again, so here's this table, the diagnostic evaluation for multiple sclerosis. Pause so you can read it all. The treatment goal in MS is to prevent exacerbations, decreased MRI lesion burden, and control symptoms. Disease-modifying drugs are initiated with diagnosis and include corticosteroids, immunosuppressants, and immune system modulators. They suppress circulating immune cells, inhibit passing the blood-brain barrier, and decrease the inflammatory response. Continuous monitoring is important because of the increased risk for infection when taking these drugs. Acute relapses are treated with corticosteroids to speed recovery. Both oral and injectable immunosuppressants and immune system modulators are used to decrease the number of relapses, promote remyelination and repair, prevent demyelination, suppress selective B and T cell function, and prevent disability. New agents are under investigation. Vitamin D supplementation may reduce the risk of MS and promote a more favorable progression. Stem cell therapy is under investigation. Symptom management for fatigue, weakness, vertigo, ataxia, tremor, heat intolerance, spasticity, bladder dysfunction, bowel dysfunction, sexual dysfunction, sensory sensation, pain, cognitive difficulties, depression, and psychosocial issues is essential to improve quality of life. Many treatments are only partially effective, particularly for fatigue and spasticity. Supportive and rehabilitative management is directed towards preventing the complications of immobility, especially pressure sores and infections of the pulmonary and genitourinary systems. Interdisciplinary inpatient rehabilitation may improve function in the short term. Supportive care includes participation in regular exercise programs, cessation of smoking, and avoidance of overwork, extreme fatigue, and heat exposure. Leading us to Guillain-Barré. Guillain-Barré syndrome is a rare demyelinating disorder caused by a humoral and cell-mediated immunologic reaction directed at the peripheral nerves. The subtype and their features are presented in the following table. Guillain-Barré syndrome usually occurs after a respiratory tract or gastrointestinal infection and has been associated with surgery, immunization, and viral infections, including the Zika virus. In axonal forms, Guillain-Barré it is proposed that molecular mimicry of pathogen-borne antigens lead to degeneration of cross-reactive antibodies that target axonal gangliosides at the nodes of Ranvier, activate, complement, and disrupt nerve conduction in peripheral motor nerves. So here's the table 1811, the expanded classification of Guillain-Barré. Again, hit pause if you're unfamiliar with Guillain-Barré. Let's see if I can stick it so that you get the most at one time. The clinical manifestations can vary from ascending flaccid paresis, starting in the legs, to complete quadriplegia, respiratory insufficiency, and autonomic nervous system instability. Diagnostic criteria include progressive weakness of more than two limbs, areflexia, and progression for no more than 4 weeks. IV immunoglobulin and plasmapheresis is used during the acute phase and followed by aggressive rehabilitation. A monoclonal antibody to human complement is under investigation. Recovery occurs within weeks to months, or up to 2 years. About 30% of individuals have residual weakness. So, peripheral nervous system disorders and neuromuscular junction disorders. Peripheral nervous system disorders, neuropathies. Neuropathies are disease processes that injure axons traveling to and from the brainstem and spinal cord neuronal cell bodies. The injury may affect distinct anatomic areas of the axon, or the spinal nerves may be injured at the root, at the plexus before peripheral nerve formation, or at the peripheral nerves themselves. The cranial nerves do not have roots or plexuses, so are not affected only within themselves. Autonomic nerve fibers may be injured as they travel in certain cranial nerves or emerge through the ventral roots and plexuses to pass through the peripheral nerves of the body. Neuropathies can be classified as generalized symmetric polyneuropathy, generalized neuropathy, and focal or multifocal neuropathy. Generalized symmetric polyneuropathy are characterized by symmetric involvement of sensory, motor, or autonomic fibers, although, with clinical signs, one type of fiber may predominate. Generalized symmetric polyneuropathies further subdivide into distal axonal polyneuropathy and demyelinating polyneuropathy. Distal axonal polyneuropathy affects peripheral axons and is generalized peripheral neuropathy commonly seen. The clinical feature of distal axonal polyneuropathy is initial involvement in the longest nerve of the body, those going to the feet. Sensory impairment is greater than motor impairment. Symptoms are burning pain, tingling, and numbness of the feet. Small nerve fibers damage produces decreased pain and temperature sensation, as well as burning, numbness, and tingling. Large nerve fibers injury causes decreased light touch, vibration, and position sense. The two most common causes are diabetes mellitus and alcohol abuse. Occasionally, neurotoxic therapeutic agents also are the cause. Within the classification of distal axonal neuropathies is another group of neuropathies called autonomic neuropathy. This neuropathy can involve virtually any sympathetic or parasympathetic nerve fiber with an impairment of cardiovascular, gastrointestinal, urogenital, thermoregulatory, pseudomotor, and pupillomotor autonomic function. Autonomic neuropathies have a progressive course and are usually reversible. The myelin or Schwann cells are affected in demyelinating polyneuropathy, which occur far less frequently. Weakness is the predominant sign, with far less sensory impairment. Acute and chronic inflammatory demyelinating neuropathies make up this group, of which Guillain-Barré syndrome is the most widely recognized disorder. Generalized neuropathies affect the cell body of only one type of peripheral neuron. The dorsal root ganglion cell is affected in sensory neuropathies, producing numbness that may begin in the focal or asymmetric distribution or in a distal symmetric pattern. Sensory neuropathies are seen in leprosy, some industrial solvent poisonings, some hereditary disorders, and chloramphenicol toxicity. Motor neuropathies are caused by anterior horn cell disease, such as amyotrophic lateral sclerosis or paralytic poliomyelitis. There is weakness or paralysis that may be symmetric or asymmetric. Focal neuropathy or multifocal neuropathies affect sensory and motor fibers in one or more nerves, as is seen in common compression neuropathies, such as carpal tunnel syndrome, ulnar nerve compression, peroneal nerve compression, or sciatic nerve compression. Focal neuropathies can involve one or more cranial nerves. Plexus injuries and radiculopathies also fall into this category. Your pathophysiology. Although distinct, pathophysiologic processes are recognized in neuropathy. These are not disease-specific and may exist simultaneously in any one neuropathy. Pathologic processes that may be present include Wallerian degeneration, in which the axon and myelin distal to the site of axonal interruption degenerate. This type of degeneration is characteristic of a traumatic nerve injury in which the nerve is severed. Axonal degeneration is caused by metabolic failure within an axon or vascular ischemia. In axonal degeneration, distal degeneration of the axon occurs first and is followed by degeneration of the myelin and the axis cylinder. This results in stocking and glove sensory or motor symptoms. In demyelinating neuropathies, the axon may be spared and only the myelin degenerates. Electromyography and ultrasound can assist in differentiating axonal from demyelination neuropathies. Many pathologic processes may give rise to neuropathy, and one or more nerves may be involved. Clinical manifestations. When the axons are affected, muscle strength, muscle tone, and muscle mass also are affected. Whole muscles or groups of muscles are paretic or paralyzed, and the muscles of the feet and legs often are affected first and more severely. These long, large axons are thought to be vulnerable to injury because of their size and length, have more Schwann cell available to their injury, and exhibit a dying back phenomenon caused by difficulty of the nerve cell body in maintaining the terminal portion of the axon. If unchecked, the pathologic process tends to invade and involve the hands and arms because these have the next longest and largest axons. Tone and the deep tendon reflex in the affected muscles generally are decreased in a neuropathy. Atrophy is distributed according to the peripheral nerves involved. The degree and distribution of the atrophy probably depends on the extent of the injury. Fasciculation may be present, especially with associated ventral root or motor neuron change, or both. As in Guillain-Barré syndrome, diabetic neuropathy, and porphyric neuropathy, mild fatigue may be experienced. A few disorders, notably Guillain-Barré syndrome, produce a pattern of paresis and paralysis that involves all limbs, the trunk and the neck. Peripheral bifacial and other cranial nerve palsies may be seen with a variety of disorders. Tenderness of the nerve trunk and associated sensory alteration help to distinguish neuropathy from amyotrophy. These include paresthesias and dysesthesias, as well as a decreased or absent primary sensation. Ataxia of gait or limb may arise from the loss of precision and vibratory sensation, and may be enhanced by motor weakness. Reflexes may also be altered. Reflex-mediated autonomic nervous system functions such as sweating, pupillary size, bladder, gastric, intestinal, and cardiovascular function may be affected. Neuropathies associated with autonomic disturbances include diabetic mellitus, alcoholism, and related nutritional neuropathies, amyloidosis, porphyria, Guillain-Barré syndrome, Rayleigh-Day syndrome, and familial sensory neuropathy. In many chronic polyneuropathies, the feet, hands, and spine become deformed, Metabolic changes may arise secondary to nerve dysfunction. So, evaluation and treatment. The diagnostic workup to determine the cause of neuropathy is often extensive. Early diagnosis and treatment before irreversible neuronal cell damage ensues are of paramount importance. Although axonal regrowth and recovery of function may take months, many neuropathies can be reversed. The therapeutic management is directed first at elimination of the cause if possible. At least the primary disorders such as diabetes should be controlled. Further damage of the axon must be prevented by avoiding trauma from premature demand for reuse of the nerve, accidents that cause tissue damage, hypoxia and ischemia, or other deprivation of essential substrates. Radiculopathies. Radiculopathies are disorders of spinal nerve roots. As the spinal roots emerge from or enter the vertebral canal, they may be injured or damaged by compression, infection, inflammation, ischemia, or direct trauma, whereby the roots are stretched or torn. Cervical and lumbar nerve roots are more commonly affected. Radiculitis refers to an inflammatory disorder of the spinal nerve roots. One or more roots may be affected. The pathophysiology. Many different pathologic conditions may cause tearing, compression, or inflammation of nerve roots. Roots may be traumatized by a forceful tearing of a nerve, termed avulsion, often associated with injuries to the head and shoulder. An acute intervertebral disc prolapse, degenerative spondyloarthropathies, or benign tumors may compress nerve roots. Metastatic tumors of the lung, breast, and gastrointestinal tract may produce a carcinomatous meningitis, causing compression and inflammatory changes in nerve roots. Other causes of inflammatory changes in the nerve roots are chronic meningitis, neurosyphilis, sarcoidosis, and inflammatory arachnoiditis, produced by myelography and lumbar puncture, leading us to clinical manifestations. The strength, tone, and bulk of the muscles innervated by the involved roots are affected. The pattern and distribution of weakness and atrophy are similar to those of the amyotrophies. Tone and deep tendon reflexes are decreased, but rarely absent because the involved muscles are usually innervated by two or more spinal roots. Fasciculations are present and mild fatigue may be experienced because pathologic processes usually affect the ventral as well as the dorsal roots. Sensory alterations are common. Disease that involve spinal roots typically produce local pain, pain on local percussion, pain and paresthesias in the sensory root distribution, increased pain with movement, stretching of the root, and maneuvers that transiently increase CSF pressure, sensory loss in a radicular pattern, and spasm of the muscles surrounding the vertebral column. Evaluation and treatment. Diagnostic measures may include physical examination, spinal films, nerve conduction studies, electromyograms, lumbar puncture with CSF examination, myelography, and biopsy of tumor masses. Treatment is directed at the cause of the injury and may take the form of surgical intervention, antibiotic administration, removal of injurious agents, corticosteroid use, and radiation therapy, as well as chemotherapy. Supportive management may control of the discomfort, protection from further injury, prevention of complication, and rehabilitation when appropriate. Plexus injuries. Nerve plexus injuries involve the nerve plexus distal to the spinal root, but proximal to the formation of the peripheral nerves. Such injuries may be caused by trauma, compression, or infiltration, or they may be iatrogenetic, caused by positioning during surgery or by an intramuscular injection. Clinical manifestations include motor weakness, muscle atrophy, and sensory loss in affected areas. Paralysis can occur with complex plexus lesions. The diagnosis is made on the basis of history and clinical manifestations. Therapeutic treatment is directed at removal of the cause, surgical repair and approximation of the nervous tissue, nerve transfer, growth factor, prevention of further injury, control of discomfort, prevention of complications, and rehabilitation when appropriate. Neuromuscular junction disorders. Transmission of the nerve impulse at the neuromuscular junction requires the release of adequate amounts of neurotransmitters from the presynaptic terminals of the axons and effective binding of the released transmitters to the receptors on the membranes of the muscles. Botulism is a food poisoning resulting from the botulinum neurotoxin being released from the Clostridium botulinum. The toxins are the most potent known and act at the myoneural junction, inhibiting the release of acetylcholine and causing severe flaccid paralysis, including respiratory paralysis and death. Other forms of C. botulinum contaminated wounds, infant and adult intestinal botulism released from spores that grow in the intestinal after eating contaminated food, and iatrogenic botulism from accidental overdose of botulinum toxin. The endospores are resilient and resistant to heat. All forms are life-threatening and require emergency treatment. Treatments include supportive care with mechanical ventilation and antitoxin. Neuromuscular junction disorders, whose pathogenesis is caused by autoantibodies, include myasthenia gravis and Lambert-Eaton myasthenic syndrome. In addition, there are rare inherited congenital myasthenic syndromes that result from mutation in different key proteins for the postsynaptic nicotinic acetylcholine receptor, ion channels, and motor end plates at the neuromuscular junction. Myasthenia gravis is a chronic autoimmune disease mediated by acetylcholine receptors, antibodies that act at the neuromuscular junction. About 20,000 to 70,000 people in the US have this disease. Myasthenia gravis is associated with an increased incidence of other autoimmune diseases, including systemic lupus erythematosus, rheumatoid arthritis, polymyositis, and thyrotoxicosis. The etiology of myasthenia gravis is unknown. Some persons have genetic susceptibility related to variants in AChR genes, as well as the major histocompatibility genes, and they may present with varying clinical phenotypes. Presynaptic autoimmune diseases are rare and include Lambert-Eaton myasthenic syndrome, with autoantibodies to calcium channels on presynaptic nerve terminals, which present with muscle weakness and is commonly associated with a small cell lung carcinoma. So here you have a picture of antibodies and myasthenia gravis. This table here shows the mechanism of action at the neuromuscular junction. Again, please pause so you know the differences. The subtypes of autoimmune myasthenia gravis are generalized acetylcholine, ocular, and neonatal. Generalized acetylcholine myasthenia gravis is further subdivided based on age and thymic pathology into the following category: early onset, young person, mostly female, with thymomas. Generally begins with ocular weakness, followed by generalized weakness. Late onset is in males, 60 years or older, without thymomas, and then person of both sexes with thymomas. Generalized acetylcholine myasthenia involves the proximal musculature throughout the body and has several courses: a course with periodic remission, a slowly progressive course, a rapid progressive course, a fulminating course. Classification by disease severity is as follows. Class 1. Any eye muscle weakness, possible ptosis, no other evidence of muscle weakness elsewhere. Class 2. Eye muscle weakness of any severity, mild weakness of other muscles. Type A. Predominantly limb or axial muscles. B. Predominantly bulbar or respiratory muscles. Type 3. Eye muscle weakness of any severity, moderate weakness of other muscles. A. Predominantly limb or axial muscles. B. Predominantly bulbar or respiratory muscles. Type 4. Eye muscle weakness of any severity, severe weakness of other muscles. A. Predominantly limb or axial muscles. And B. Predominantly bulbar or respiratory muscles, or both. And type 5. Intubation needed to maintain airway. In neonatal myasthenia gravis, transitory signs of myasthenia gravis are present in 10 to 15% of infants born to mothers with myasthenia gravis. The signs appear 1 to 3 days after birth and persist for a few days to a few weeks. Myasthenia immunoglobulin is transferred from the mother to the neonate through the placenta. Ocular myasthenia, which is more common in males, involves weakness of the eye muscles and eyelids and may include swallowing difficulties and slurred speech. The pathophysiology. Myasthenia gravis results from a defect in nerve impulse transmission at the neuromuscular junction. The main defect is a T-cell dependent formation of autoantibodies, your IgG antibody, against nicotinic acetylcholine, muscle-specific kinases, lipoprotein-related protein 4, or agrin in the postsynaptic membrane at the neuromuscular junction. Agrin is the component of muscle-specific kinase receptor function. The autoantibodies destroy acetylcholine through antibody-mediated complement activation. The cause of this autosensitization is unknown. Destruction of receptor sites occurs, decreasing the number of receptors on the plasma membrane and causing diminished transmission of nerve impulses across the neuromuscular junction. Muscle depolarization is incomplete or unsuccessful. About 10 to 50% of individuals with myasthenia gravis do not have acetylcholine antibodies on testing, but have muscle-specific kinases antibodies. This is now subtyped MuSK antibody-associated myasthenia gravis. Clinical manifestations. Myasthenia gravis has an insidious onset. The variable distribution of ACH receptor sites or the number of and different isoforms of antibodies may determine when and which muscle groups are affected first. Usually the muscles of the eyes, face, mouth, throat, and neck. The extraocular muscles and the levator muscles are most affected. Manifestations include diplopia, ptosis, and ocular palsies. The muscles of facial expression, gesticulation, swallowing, and speech are the next most involved. The results are facial drop and an expressionless face, difficulty swallowing, chewing, associated with dietary changes and weight loss. Drooling, episodes of choking and aspiration, and a nasal, low volume but high-pitched, monotonous speech pattern. The muscles of the neck, shoulder, girdle, and hip flexors are less frequently affected, but muscle fatigue is common after exercise and there can be progressive weakness. The respiratory muscles of the diaphragm and chest wall become weak, with impaired ventilation. Impairment in deep breathing and coughing predisposes the individual to atelectasis and congestion. MuSK antibody type Mg often involves severe swallowing and breathing problems. Clinical manifestations may first appear during pregnancy, during the postpartum period, or in conjunction with the administration of certain anesthetic agents. The progression of myasthenia gravis varies, appearing first as a mild case that spontaneously remits with a series of relapses in symptom-free intervals ranging from weeks to months. Over time, the disease can progress and all muscles are weak. Myasthenic crisis occurs when severe muscle weakness causes extreme quadriparesis and quadriplegia, respiratory insufficiency with shortness of breath, and a marked decreased tidal volume and vital capacity, and extreme difficulty in swallowing. The individual in myasthenic crisis is in danger of respiratory arrest. Cholinergic crisis may arise from anticholinesterase drug toxicity with increased intestinal motility, episodes of diarrhea, and complaints of intestinal cramping, bradycardia, pupillary constriction, increased salivation, and diaphoresis. The clinical picture resembles that of myasthenia crisis, but the weakness occurs 30 to 60 minutes after taking anticholinergic medication. The clinical manifestations are caused by the smooth muscle hyperactivity secondary to excessive accumulation of acetylcholine at the neuromuscular junction and excessive parasympathetic-like activity. As in myasthenia crisis, the individual is in danger of respiratory arrest. So, evaluation and treatment. The diagnosis of myasthenia gravis is made on the basis of a response to endrophonium chloride, tensilon, results of results of EMG studies, and detection of acetylcholine and MuSK antibodies. With the intravenous administration of the drug, immediate demonstrable improvement in muscle strength usually persists for several minutes. Mediastinal tomography and MRI help determine whether a thymoma is present. Treatment of MG is individualized. Anticholinesterase drugs, corticosteroids, immunosuppressant drugs are all used to treat MG and myasthenic crisis. Plasmapheresis may be life-saving during myasthenic crisis, before and after a thymectomy, and at the start of immunosuppressant therapy. For individuals with cholinergic crisis, treatment is to withhold anticholinergic drugs until blood level falls out of the toxic range, while providing ventilatory support and preventing respiratory complications. Thymectomy is the treatment of choice for a thymoma. Complement inhibitors are being evaluated. Current treatment for MG have improved prognosis, including in those who have ocular myasthenia. Tumors of the central nervous system. Central nervous system tumors include brain and spinal cord tumors. The incidence of CNS tumors increases to age 70 years and decreases then. CNS tumors are the second most common group of tumors occurring in children. Roughly 70 to 75% of all intracranial tumors in children are located infratentorially, and 70% are located supratentorially in adults. Peripheral nerve tumors are rare in children and common in adults. Carcinogenesis is discussed in Chapter 12, pituitary tumors are discussed in Chapter 22, and cerebral tumors are discussed in Chapter 20. So brain tumors. Brain tumors can be both malignant and non-malignant, had an estimated incident rate of 80,000 with about 17,000 deaths in 2017 in the US. Tumors within the cranium can be either primary or metastatic. Primary brain tumors originate from the brain substance, including neuralgia, neuron, cell of blood vessels, and connective tissue. Extracerebral tumors originate outside substances of the brain and include meningiomas, acoustic nerve tumors, and tumors of the pituitary and pineal glands. Metastatic brain tumors arise in organ systems outside the brain and spread to the brain. Sites of intracranial tumors are illustrated here in this following figure. Intracranial brain tumors do not metastasize as readily as tumors in other organs because there are no lymphatic channels within the brain substance. If metastasis does occur, it is usually through seeding of cerebral blood, through CSF, during cranial surgery, or through artificial shunts. Cranial tumors cause local and generalized clinical manifestations. The local effects are caused by the destructive action of the tumor itself on a particular site in the brain, and compression, causing decreased cerebral blood flow. The effects are varied and include seizures, visual disturbances, unstable gait, and cranial nerve dysfunction. The generalized effects include increased ICP. Increased ICP may occur because of obstruction of the ventricular system, hemorrhage occurring in and around the tumor, cerebral edema caused by tumors, or expansion of the tumor mass. So, primary brain tumors, intracerebral. Primary brain tumors constitute about 2% of all cancers in the US. Gliomas comprised of about 25% of all adults in primary brain tumors and 75% of malignant brain tumors. Gliomas include astrocytomas, oligodendrogliomas, mixed oligogastrocytomas, and glioblastomas. Multiform. The World Health Organization divides gliomas into 4 grades based on histopathology features, cellular density, atypia, mitotic activity, microvascular proliferation, and necrosis. Grades 1 and 2 are generally benign or slow-growing and well to moderately differentiated. Grade 3 and 4 are malignant tumors and poorly differentiated. Other CNS tumors include meningiomas, ependymomas, nerve sheath tumors, and neurofibromas. Etiology for primary brain tumors is not clearly known. Ionizing radiation is the only known environmental risk factor. The association between mobile phone use and gliomas and acoustic neuromas is controversial. So here you have brain and spinal cord tumors. Again, hit pause so you can figure out the differentiation. Molecular characteristics of gliomas include mutation of the isocitrate dehydrogenase gene, or, less commonly, mutation of the related IDH2 gene, identified in the vast majority of the World Health Organization. Grade 2 and 3 astrocytic, oligodendroglial, and oligogastrocytic gliomas, silencing of the MGMT gene, is found in astrocytomas. Mutant epidermal growth factor 8 amplification is found in most subtype gliomas. Chromosome 1p and 19q deletions are associated with oligodendrogliomas, and gliomas may arise from cancer-initiating resident stem cells. The principal treatment for cerebral tumors is surgical or radiosurgical excision or surgical decompression if total excision is not possible. Chemotherapy, radiation therapy, or their combination may be used. The blood-brain barrier is an obstacle to the delivery of chemotherapeutic agents. New methods are in progress for penetration of this barrier, including nanoparticle drug carriers and focused ultrasound combined with microbubbles. Specificity of treatment is advancing with the development of vaccines, cell therapy, reshaping of the tumor microenvironment, immune checkpoint inhibitors, and modified poliovirus. Astrocytomas. Astrocytomas are the most common glioma, about 75% of all tumors in the brain and spinal cord. These tumor cells develop from astrocytes and are believed to have lost normal growth restraint and thus proliferate uncontrollably. Astrocytomas are graded 1 through 4. They may occur anywhere in the brain or spinal cord and are generally located in the cerebrum, hypothalamus, or pons. Low-grade astrocytomas tend to be located laterally or supratentorially in adults and in the posterior fossa in children. Headache and subtle neurobehavioral changes may be early signs, with other neurologic symptoms evolving slowly with increased ICP, occurring late in the tumor course. Onset of the focal seizures disorders between the second and sixth decade of life suggests an astrocytoma. Low-grade astrocytomas are treated with surgery or by external radiation, and at least 50% of persons survive 5 years when surgery is followed by radiation therapy. Grades 3 and 4 astrocytomas are found predominantly in the frontal lobes and cerebral hemispheres. Although they may occur in the brainstem, cerebellum and spinal cord, men are twice as likely to have astrocytomas as women. In the 15 to 34-year-old age group, they are the third most common brain cancer, whereas the 35 to 54-year-old age group, they are the fourth most common. So here you have a well-differentiated infiltrating astrocytoma and a glioblastoma multiforme in the brain. Grade 4 astrocytoma glioblastoma multiforme is the most lethal and most common type of brain tumor. Your glioblastoma multiforme is highly vascular and extensively irregular and infiltrative, making them difficult to remove surgically. 50% of glioblastomas are bilateral or at least occupy more than one lobe at a time of death. The typical clinical presentation for a glioblastoma multiforme is that of diffuse, nonspecific clinical signs, such as a headache, irritability, and personality changes that progress to more clear-cut manifestations of increased ICP, including headache on position change, papilledema, vomiting, and seizure activity. Symptoms may progress to include definite focal signs, such as hemiparesis, dysphagia, dyspraxia, cranial nerve palsies, and visual field deficits. Treatment for newly diagnosed GBM is radiotherapy with temozolomide, following maximal surgical resection. Adjuvant immunotherapy may be beneficial. Survival at 5 years of grades 3 and 4 astrocytoma is about 5 to 10%. Your oligodendroglioma constitutes 2% of all primary brain tumors and 10 to 15% of all gliomas. They are typically slow-growing tumors. Most oligodendrogliomas are macroscopically indistinguishable from other gliomas and may be a mixed type of oligodendroglioma and astrocytoma. The majority are found in the frontal and temporal lobe, often in the deep white matter, but they are also found in other parts of the brain and spinal cord. Many are found in young adults with a history of temporal lobe epilepsy. Malignant degeneration occurs in approximately one-third of persons with oligodendrogliomas, and the tumors are then referred to as anaplastic oligodendroglioma. More than 50% of individuals experience a focal or generalized seizure as the first clinical manifestation. Only half of those with an oligodendroglioma have increased ICP at the time of diagnosis or surgery, and only one-third develop focal manifestations. Those with 1p19q co-deletion experience a benefit from adding chemotherapy to radiation. Ependymoma. Ependymoma are non-capsulated gliomas that arise from ependymal cells that form the walls of the ventricles or the spinal canal. They are rare in adults, usually occurring in the spinal cord. They comprise about 6% of all primary brain tumors in adults and 10% in children and adolescents, usually occurring in the intracranial location. Approximately 70% of these tumors occur in the fourth ventricle, with others found in the third and lateral ventricles. and caudal portion of the spinal cord. Roughly 40% of infratentorial ependymomas occur in children younger than 10 years of age. Cerebral ependymomas occur at all ages. Fourth ventricle ependymomas present with difficulty in balance, unsteady gait, uncoordinated muscle movement, and difficulty with fine motor movement. The clinical manifestation of a lateral and third ventricle ependymoma that involves the cerebral hemisphere are seizures, visual changes, and hemiparesis. Blockage of the CSF pathway produces hydrocephalus and presents with headache, nausea, and vomiting. Ependymomas are treated with surgical resection and adjuvant radiotherapy and chemotherapy. About 20 to 50% of the people survive 5 years. Some persons benefit from a shunting procedure when the ependymoma has caused a non-communicating hydrocephalus. So primary extracerebral tumors, apologies. Meningioma. Meningioma constitutes 36% of all primary brain tumors and is more common in women. Predisposing factors include the neurofibromatosis type 2 and undergoing ionizing radiation after a several decade latency period. Formation of benign meningiomas has been linked to NF2 gene mutation and chromosome 22q12-2 loss, along with the DAL1 loss on chromosome 18. Atypical and anaplastic meningiomas have been linked to additional gene alterations involving other multiple chromosomes. They are resistant to treatment. A meningioma is sharply circumscribed and adapts to the shape it occupies. It may extend to the dural surface and erode the cranial bones, or produce an osteoblastic reaction. A few meningiomas exhibit malignant invasive qualities. So here we're taking a look at a meningioma. Meningiomas are slow growing, and clinical manifestations occur when they reach a certain size and begin to indent the brain. Parenchyma. Focal seizures are often the first manifestations, and increased ICP is less common than with gliomas. Other symptoms are related to the site of the tumor location. So we have excuse me, five things here. One, the sphenoidal wing, ophthalmoplegia, mild proptosis, and involvement of the ophthalmic division of the trigeminal nerve. Olfactory groove, anosmia, personality change, and visual failure. Parasagittal, a focal seizure of the focal motor or sensory deficit. Paracellar, evidence of chiasmatic compression, urinary incontinence, dementia, gradual paraparesis, hormonal failure, optic atrophy, bitemporal hemianopia, and lateral convexity, variable depending on structures compressed, including slow hemiparesis, speech abnormalities. Because of the extremely slow-growing nature of most meningiomas, increased ICP is less common than with gliomas. Diagnosis is made using contrast-enhanced CT, MRI, or both. The primary treatment is surgical resection. Stereotactic radiotherapy is used with incomplete resection or recurrence rate of 20%. Your nerve sheath tumors. Nerve, nerve sheath tumors are either neurofibromas or schwannomas. Neurofibromas are a group of autosomal dominant disorders of the nervous system. They include neurofibromatosis type 1 and neurofibromatosis type 2. NF1 and NF2 are also known as peripheral and central neurofibromatosis, respectively. Neurofibromatosis type 1 is the most prevalent, with an incidence of about 1 in 3,500 people, and causes multiple cutaneous neurofibromas, cutaneous macular lesions, and less commonly bone and soft tissue tumors. Inactivation of NF1 gene results in loss of function of neurofibromin in Schwann cells and promotes tumor tumorigenesis. Learning disabilities are present in about 50% of affected individuals. NF2 is rare and occurs in about 1 in 60,000 people. The NF2 gene product is a tumor suppressant protein. Mutation promote development of central nervous system tumors, particularly schwannomas, although other tumor types can occur. Benign bilateral schwannomas of the vestibular nerves present with hearing loss, progressing to deafness, dizziness and balance problems, tinnitus, and facial nerve paralysis. Other symptoms may include loss of balance and dizziness. Schwannomas also may develop in other cranial, spinal, and peripheral nerves, and cutaneous signs are less prominent. Intracranial meningiomas can involve the optic nerve with loss of visual acuity and cataracts, or can be intraspinal with formation of ependymomas. Genetic testing is available for the management of families susceptible to NF, and a prenatal diagnosis is possible. Diagnosis is based on the clinical manifestation and neuroimaging studies. Criteria for the diagnosis of NF type 1 and 2 are in box 18.3. So again, hit pause so you can get the criteria for NF1 and NF2. Surgery is the major treatment. Individuals with NF2 have extensive morbidity and reduced life expectancy, particularly with early age of onset. Molecular target therapies are likely to provide personalized treatment for both of these devastating conditions. That leads us to metastatic brain tumors. Metastatic brain tumors from systemic cancers are roughly 10% times more common than primary brain tumors. 10 to 20% of persons with cancers have metastasis to the brain. Lung, 40%, and breast, 15 to 20%, are the most common tumors to have brain metastases within 1 to 3 years, following by malignant melanoma, renal cell carcinoma, and less commonly gastrointestinal and reproductive tract cancers. Metastasis to the brain is believed to be through vascular channels. The brain metastatic process requires a series of sequential events called the metastatic cascade. Peripheral cancer cells degrade the extracellular matrix, invade blood vessels and lymph nodes, migrate, extravasate, and colonize at their new location, forming a metastatic niche. Tumor cells reach the brain vasculature by attaching themselves to the endothelial cells of brain microvessels in the blood-brain barrier. Using enzymes, they disrupt the epithelial basement membranes and extravasate into the brain parenchyma. They can attach platelets that protect them from immune defenses. Local brain invasion requires cell motility, adhesion, survival, and proliferation. They induce blood vessel development and proliferate in response to growth factor cytokines and chemokines. The cerebrum is the most common site of seeding. Metastatic brain tumors produce signs resembling those of glioblastomas, although several unusual syndromes do exist. Carcinomatous encephalopathy causes headaches, nervousness, depression, trembling, confusion, forgetfulness, and gait disorders. In carcinomatosis of the cerebellum, headache, dizziness, and ataxia are found. Carcinomatosis of the craniospinal meninges manifests with headache, confusion, and symptoms of cranial or spinal nerve root dysfunction. Your contrast-enhanced CT and MRI imaging techniques are most sensitive imaging procedures for metastatic brain tumors. Treatment is guided by the pathology of the original tumor, number, size, and location of the brain metastasis, and prior cancer treatments. Corticosteroids and anti-epileptic drugs can help relieve symptoms. One of the four lesions are treated with stereotactic radiosurgery. Chemotherapy is considered when surgery or radiation therapy is not possible. With the development of new drugs that cross the blood-brain barrier, chemotherapy is increasingly recommended. Survival with treatment is roughly 1 year. Spinal cord tumors. Primary spinal cord tumors are rare and represent about 2% of CNS tumors. They are histologically classified as extradural, intradural, extramedullary, and intradural intramedullary. Your extramedullary tumors originate from tissue outside the spinal cord. Extramedullary tumors are either peripheral nerve sheath tumors or meningiomas. Neurofibromas are generally found in the thoracic and lumbar region, whereas meningiomas are more evenly distributed through the spine. Complete resection of these tumors can be curative. Other extramedullary tumors are sarcomas, vascular tumors, chordomas, and epidermoid tumors. Intramedullary tumors are the excuse me. Intramedullary tumors are least common and originate within the neural tissue of the spinal cord. Intramedullary tumors are primarily gliomas. Gliomas are difficult to resect completely, and radiotherapy is required. Spinal and ependymomas may be completely resected and are more common in adults. Metastatic spinal cord tumors are usually carcinomas, lymphomas, or myelomas. Their location is often extradural, having proliferated to the spine through direct extension from tumors of the vertebral structures or from extraspinal sources, extending through the interventricular foramen or bloodstream. They are 3 to 4 times more common than primary spinal cord tumors. Pathophysiology. Extramedullary spinal cord tumors produce dysfunction by compression of adjacent tissue, not by direct invasion. The spinal cord is compressed by the tumor from without, and destruction of the white matter tracts occur. The spinal canal around the cord becomes filled by tumor. Intramedullary spinal cord tumors produce dysfunction by invasion and compression. The cord enlarges as a result of the tumor that is enlarging inside the cord. In addition, distortion of adjacent white matter tracts occurs. Metastases from spinal cord tumors occur through seeding through the CSF. Medulloblastomas and ependymomas establish distant implants in this manner. So clinical manifestations. Clinical manifestations depend on growth rate, location, and longitudinal extent of the tumor. An acute onset suggests a vascular occlusion of vessels supplying the spinal cord, whereas gradual and progressive symptoms suggest compression with dural distension and irritation. Pain is usually a presenting symptom. The compressive syndrome involves both the anterior and posterior spinal tracts and nerve roots, and motor function and sensory function are affected as the tumor grows, with weakness, spasticity, and clumsiness, and a decrease in pain and temperature sensation. The irritative syndrome combines the clinical manifestation of cord compression with radicular pain that occurs in the sensory root distribution and indicates root irritation. The segmental manifestations include segmental sensory changes, such as paresthesias, and impaired pain and touch perception. Motor disturbances, including cramps, atrophy, fasciculations, and decreased or absent deep tendon reflexes, and continuous spinal pain. Our evaluation and treatment. The diagnosis of a spinal cord tumor is made using MRI techniques, bone scans, PET scans, CT-guided needle biopsies, or ovum biopsies. Involvement of specific cord segments is established. Any metastases are also identified. Spinal tumors are not staged, but can be classified as slow-growing or rapid-growing. Treatment varies depending on the nature of the tumor and the person's clinical status, but surgery is essential for all spinal cord tumors. Radiotherapy, chemotherapy, hormonal therapy, and pain management protocols may all be appropriate. And that concludes this chapter. As always, I thank you for watching, and I'll see you with the next chapter, which I believe is chapter 20.